So good morning everyone. Dr. Abhilasha Samkar, she is a pediatric hemato-oncologist working as a professor at JNMC Medical College, Belgaum. She has numerous publications in very reputed journals, and she has also contributed to pediatric hemato-oncology textbooks also. I welcome you, Dr. Abhilasha. Over to you.
Thank you. Very good morning to all of you. At the outset, I would like to thank the organizers of Kapcon for giving me this opportunity. It's always great to come to Kolhapur and get a chance to speak among the supremely enthusiastic pediatricians of this place. So the topic given to me is thrombocytopenia. So I'll be putting up few cases. But before we go to the cases, just briefly, I would like to give the overview of function of platelets and its role in hemostasis and how it interacts with the other factors, especially the von Willebrand factors, because there are other conditions apart from thrombocytopenia per se, like von Willebrand disease or some qualitative disorders where we do get thrombocytopenias. So we all know about the Virchow's triad of hemostasis. So whenever there is any injury to the blood vessel wall, the collagen is exposed. Now, once this collagen is exposed, the first thing to happen is obviously vasoconstriction, and then the platelets are recruited to the site of injury, and the platelets through their receptors, and mainly the von Willebrand factors tend to adhere to this exposed collagen. Now once they have adhered to this exposed collagen through their receptors, they get activated. We can see these platelets with the pseudopods or dendrites. So these are the activated platelets which in turn release ATP and thromboxane. These are adhesive molecules, and then they help the platelets to aggregate. So adhesion, aggregation. And once these activated platelets have aggregated, they then stimulate the coagulation cascade. Then the intrinsic factors and the extrinsic factors come into action. So the subsequent cases which I'll be putting up, so we have to keep in mind that the problem can be due to these receptors on the surface of the platelets, these glycoprotein receptors, that is GP1B9, GP2B3A, or any problem with the von Willebrand factor. So what is thrombocytopenia in children? So ideally, any platelet count of less than 1.5 lakhs is theoretically a thrombocytopenia, but for practical purpose, if the platelet count is less than 1 lakh, then we call it thrombocytopenia. So the extent of bleeding obviously depends on the platelet count if it is an isolated platelet defect. But if there are other conditions involved along with the platelet disorder, then it does not depend on the platelet count. So if the platelet count is above 50,000, then they are rarely symptomatic. They are just diagnosed because they are posted for some surgery or on routine investigations. If the platelet count is less than 50,000, then we see occasionally skin bleeds. Obviously, at a platelet count of less than 20,000, there is a risk of spontaneous mucosal bleeding. And if the platelet count is less than 5,000, then there is a risk of severe bleeds like intracranial, gastrointestinal, or genitourinary bleeds. But there is an exception. If it is ITP, even if the platelet count is less than 5,000, the chance of bleeding is extremely less, because there we have highly hemostatic platelets which are functionally very active. So a few words about the mechanisms of thrombocytopenia. So broadly, the first and the commonest category of thrombocytopenia that we see in our practice is due to increased destruction. So the commonest cause of increased destruction is obviously immune. Immune thrombocytopenia is one of the commonest problem of coagulation disorder in the pediatric age group. Next is the collagen vascular disorder, which can again lead to ITP-like condition. Then various drugs which can lead to thrombocytopenia, especially the antibiotics, post-viral, and neonatal alloimmune thrombocytopenia. So I'll be putting up all these cases in the subsequent slides. And then occasionally we do come across non-immune causes of thrombocytopenia, like microangiopathic hemolytic anemia associated conditions like hemolytic uremic syndrome or TTP, which can be congenital as well as acquired, then prosthetic heart valves and DIC. Then platelet sequestration. So this can be due to splenomegaly. We come across so many conditions in the pediatric age group where we have splenomegaly, be it storage disorder or be it hemolytic anemia like thalassemia or hereditary spherocytosis where the patient has massive splenomegaly, or portal hypertension where there can be platelet sequestration and we can get thrombocytopenia. Then hemangiomas, more commonly seen, in the neonatal age group itself, they can be having an underlying huge liver hemangioma and absolutely well-looking child with severe thrombocytopenia and bleeding. So especially if a child has any external hemangioma, we must ask for ultrasound to look to see if there is a liver hemangioma which is consuming all the platelets and causing thrombocytopenia. And last but not the least, we do come across inherited bone marrow failure syndromes leading to decreased production. So there's a huge list like Fanconi anemia, congenital amegakaryocytic thrombocytopenia, or May-Hagelin related disorders. And acquired conditions which can lead to decreased production is like aplastic anemia, drug-induced, marrow infiltration by conditions like malignancy, leukemia, lymphoma, or any malignancy for that matter which can involve the marrow, like neuroblastoma, retinoblastoma, and even viral infections, especially the Epstein-Barr virus. It's a very notorious virus which tends to involve the marrow and cause severe thrombocytopenia. So let's start with a very simple, straightforward case. A 1-year-old boy presented with swelling in the inguinoscrotal area. So our pediatric surgeon colleague diagnosed it to be an inguinal hernia and planned for surgery. So the pre-operative evaluations showed a hemoglobin, normal hemoglobin and WBC count, but the child had thrombocytopenia. The platelet count was just 20,000. Now, on examination, the child is absolutely well looking. He is not febrile. There's no skin and mucosal bleeding and no significant past or family history. So this is a case of unexpected thrombocytopenia. So I request the audience to give their inputs quickly. So what are the possibilities? The child is absolutely well looking on investigation. Exactly, sir. So this is spurious. This can be spurious or pseudothrombocytopenia. So then what we should ask for? We should ask for a direct finger prick sample. And what we can see here, these are platelet clumps. So usually the platelet clumps are seen only if the platelet count is more than 50,000. So these platelet clumps, they suggest that here the platelet count is more than 1 lakh and it is a spurious. It is pseudothrombocytopenia. It is a common condition which happens because the platelets develop anti-EDTA antibodies, and routinely we collect the sample in the EDTA bulb. So this is in vitro clumping in EDTA containing tubes. So we should look for clot in the tubes, and in this condition, the quickest way is to take a direct finger prick sample and smear it and see it under the microscope, or we can do the platelet count in citrate bulb or heparin bulb. Whenever we are taking sample in pediatric age group, it's not very easy to take the sample. We should always follow the WHO guidelines on drawing the blood. That is the best practices in phlebotomy guidelines of WHO. So the sampling technique should be apt. It should always be a free-flowing venous blood and appropriate sample size. This is appropriate sample size, especially important for when we are asking for PT-APTT. We often get references, the child is posted for a surgery, no bleeding manifestation, but PT-APTT is deranged. Child has received FFP, but still the PT-APTT is deranged. So that happens because we are not looking at the ratio. So the ratio of the citrate to the blood sample should be 1:9, 1 part of citrate and 9 part of blood. So otherwise we can get deranged value, especially in newborn, because in newborns it is difficult to get so much sample. So for them we get a special small citrate bulb where we can maintain the ratio. Now coming to another simple case, this 4-year-old girl who was previously well and had coryzal illness, running nose 1 week ago. She also had 1-day history of bruises and petechial rashes over the limbs, and 1 episode of gum bleeding was noticed while brushing. Her hemoglobin is 12.2, the WBC count is normal, but the platelet count is just 5,000, and this has been verified manually, unlike the previous case. So she does have real thrombocytopenia, and this is the peripheral smear. What we can see here is a giant platelet. Whenever the size of the platelet is more than that of a lymphocyte, it is a giant platelet. So the diagnosis is very straightforward. It is a case of ITP. Now, before I go about the facts of ITP, we should know that 80% of the cases achieve complete remission on their own without any intervention. So counseling is the most important thing when it comes to the management of ITP. So 2/3 of the cases of ITP are preceded by infectious illnesses like upper respiratory tract infection, rubella, varicella, mumps, maybe infectious mononucleosis, and so on. Especially if there is a history of immunization with a live viral vaccine, we can consider this diagnosis. Platelet count in ITP, as I mentioned earlier, does not necessarily correlates with the severity of the bleed because they are highly active immature platelets which are very hemostatic, and in fact it is a misnomer, thrombocytopenia. They are immature platelets which are very active, and even at a low platelet count they don't bleed, and the incidence of intracranial hemorrhage in ITP is less than 0.5%. So clinical significant bleeding is seen in only 3% of the cases. So this question often comes, what are the indications for bone marrow examination? Because the American Society of Hematology guidelines suggest that bone marrow is not indicated in a typical case of ITP. That holds good for the Western countries where they have access to all the platelet indices and a good peripheral smear. But in our country, sometimes the CBC, I mean, we get the reports just from the technicians. They are not, the peripheral smear is not even looked by an experienced pathologist or a hematologist or a pediatrician. And in our country, it's very important to consider bone marrow because sometimes we may end up treating occult leukemia and we can put them into partial remission, and then it can take a long time for the disease to surface. So whenever they're in doubt, we must go for a bone marrow examination. In conditions such as if there is abnormalities on the CBC which are not explainable. For example, even if the WBC count is looking normal, say 5,000, but we must look at the absolute neutrophil count, absolute monocyte count. These two things are very important. So if the neutrophil count is on the lower side, or if you are finding that the monocyte count is on the higher side, that is a red flag sign for malignancy, and bone marrow is absolutely indicated in our scenario in such a case. If there is clinically significant hepatosplenomegaly or lymphadenopathy, if steroid therapy is contemplated, steroid is the first line drug and one of the best drug for ITP. So if the steroid therapy is contemplated, as I mentioned, to avoid partially treating occult leukemia, we must go for a bone marrow. And if there is failure to respond to frontline therapies like IVIG. Or on examination, if we have found some congenital anomaly which may be associated with inherited bone marrow failure syndrome. I mean, we do get consanguinity in this part of Maharashtra and North Karnataka, so we come across a lot of cases of inherited causes of thrombocytopenia, inherited bone marrow failure syndrome. So if there's any sign, which I'll be mentioning later, then we must go for a bone marrow. Other than that, platelet indices are of great help in the diagnosis of ITP. So there's a huge list of the indices, but I'll just cover the common ones. So mean platelet volume. So what we can see in this image, this is an immature platelet which has got these pseudopods. So these, this is how a platelet looks when it is in the bone marrow and it is about to be released in the circulation. So these are immature platelets, what we get in ITP. So the immature platelets are large in size due to these pseudopods. So they'll have higher mean platelet volume. So if the mean platelet volume is high, say more than 12, then it means we have lot of immature platelets, and probably the cause of thrombocytopenia is not a production defect but destruction. It is a peripheral destruction like ITP or any condition like SLE which is causing immune mediated destruction of the platelets. Whereas if the platelet size is small, then that suggests those are all unhealthy platelets, and that can be associated with conditions like aplastic anemia or inherited bone marrow failure or any condition where the marrow is diseased. So there we need to be cautious, and the patient requires platelet transfusion. Similarly, just like red cell distribution width, which tells us about coefficient of variation in the size and the shape of the RBCs, platelet distribution width tells us about the variation in size and shape of the platelets. And if it is high, it means that the bone marrow is trying to produce more and more platelets, and they are going to be released into the circulation soon and less chances of bleeding. This is the most important parameter of the platelets, that is immature platelet fraction. This, just like the reticulocyte count in CBC, the immature platelet fraction, as far as the platelet parameters are concerned, this is the first indicator of bone marrow recovery. And this parameter is especially very important in ITP as well as dengue. Because if the immature platelet fraction is high, rest assured the patient is highly unlikely to bleed and there is no need of any transfusion. Similarly, in dengue, if the immature platelet fraction is showing the rising trend, it means that the patient is in recovery phase. So when it comes to treatment of ITP, it's in itself is a very big topic. I cannot, due to a shortage of time, I cannot go into the depth of it. But the goal should be to always achieve a hemostatic platelet count rather than normal platelet count. That is, treat the patient and not the platelet count. If the patient is bleeding, then we need to be aggressive. Otherwise, reassurance is enough. So if there is no sign of bleeding or just grade 1 bleeding, that is just skin bleed, some small petechiae, purpura, or maybe even minor mucosal bleed, just wait and watch and wait for spontaneous recovery. Obviously, we have to counsel the patients that avoid trauma, contact sports, especially the drugs like NSAIDs and unnecessary use of antibiotics. And yeah, it is a problem in menstruating women, so they can be put on low dose progesterone, and tranexamic acid can be given, but tranexamic acid is contraindicated if the patient has hematuria because it can cause bladder colic. So why treat ITP? It is mainly for the fear of intracranial hemorrhage. When we see a platelet count of 2000, we tend to treat our anxiety rather than treating the patient. But as we know, the incidence of the incidence of intracranial bleed in ITP is extremely rare, less than 0.5%. And if intracranial bleed has to happen, it can occur irrespective of the treatment. Obviously, if there are precipitating factors, then head trauma, or if the patient is also on some antiplatelet therapy like aspirin, then there are more chances of intracranial bleed. And there are various studies, as we can see here, all over the world, various meta-analysis to back up the fact that incidence of intracranial bleed is very low in ITP, so we need not panic. So the treatment options for ITP, we all know the first line options, obviously apart from watchful waiting, is prednisolone, IVIG, anti-D. These are the as per the recommended guidelines, but my personal choice as a first line drug, if we are not if it's not just watchful waiting, is always prednisolone. This is the first factor in our scenario is the cost, but apart from that, why prednisolone is superior to IVIG is it not only binds to and it reduces the antibody load, but it has two other mechanisms of action by which it is helpful in ITP. One is it stimulates the thrombopoietin. It stimulates the production of the platelets, so it is acting there. And secondly, even if the platelet count is not increasing with prednisolone, it stabilizes the blood vessels, so it reduces the chance of bleeding. So if we don't require a very rapid rise in the platelet count, for example, conditions if there's GI bleed or anticipated intracranial bleed, where IVIG is obviously preferred drug because IVIG causes very rapid rise in the platelet. But in other cases of ITP, prednisolone should always be the first choice. If these two have not worked, we may try anti-D, which is rarely used. But if we are giving anti-D, we have to make sure that the patient is not Rh negative, and second is patient is not splenectomized. In a splenectomized or Rh negative patient, anti-D is not going to work, and this anti-D is not the anti-D which is given to pregnant ladies. There is a very different preparation, Winro, Cambro, which is quite expensive and not very easily available. Then IV methylprednisolone, actually oral steroid, if we are giving at a dose of 4 mg per kg, with a cap, we have to keep in mind that the capping dose is 80 mg for adolescents, works equally well or rather superior to IV methylprednisolone. And sometimes we may have to give dexamethasone, but we should avoid giving it for a longer time because it predisposes to fungal infections and psychosis, hypertension, a lot of complications associated with it. Now we have a lot of second line options, like the commonest being thrombopoietin receptor analogs, eltrombopag, romiplastin. Now the cost has also reduced, so these are very good drugs. Then in refractory cases, we can go for rituximab, but we should do the immunoglobulin levels before giving rituximab, and counseling is very important. They should be referred to a hematologist for this. And splenectomy is almost obsolete. But we had a case recently where the child presented with intracranial bleed and nothing was working, and we posted the child for emergency splenectomy, and just after ligating the splenic vessel, the platelet count came up within no time to 75,000, and the child could be salvaged, could be extubated. So in some conditions, it still works where everything has failed. So it is down but not out. This is the algorithm for refractory ITP. I'll not go into the details of it. If it is refractory, the child should be referred to hematologist. And but before that, we can do the workup for the secondary causes of ITP, because in pediatrics we do get cases of secondary causes of ITP, like the child can be having underlying SLE, Evans syndrome, autoimmune lymphoproliferative syndrome, or even immunodeficiencies. Some malignancies like Hodgkin's lymphoma can present with just immune thrombocytopenia or autoimmune hemolytic anemia, or a detailed history of any drug intake. So a refractory ITP should be referred to hematologist for further evaluation. Now, because we do come across the thrombocytopenia is sometimes very annoying in dengue, persistent thrombocytopenia. So these are as per the WHO guidelines, we should, if the bleeding manifestations are not bad, we can resort to the local measures as much as possible, like adrenaline nasal pack. Tranexamic acid is something which we can use very liberally if the patient is not having hematuria. Proton pump infusions, they do help in GI bleed. And there is no role for prophylactic platelet or FFP transfusion in dengue. And the aim for monitoring the platelet count in dengue is to predict the risk of plasma leakage, but not to take a call on the platelet transfusion. And as I mentioned earlier, immature platelet fractions and mean platelet volume, they are very effective tools to predict platelet recovery in dengue and take a call about platelet transfusion. So having said this, we must know when it is not ITP, because sometimes we do tend to label the cases, thrombocytopenia cases, as ITP if they don't have associated clinical features. So if the patient is having skeletal defects, if the other cell lines are involved, bicytopenia or pancytopenia, and if the bleeding is disproportionate to the severity of thrombocytopenia. So I want to put up as many cases as possible, so I'll quickly rush through this case. I have presented it many times. So just now I mentioned when the bleeding is disproportionate to the severity of thrombocytopenia, ITP should not be considered. So this 7-year-old boy presented with subconjunctival hemorrhage, skin bleeds and gum bleeding and epistaxis for 2 days. He didn't have lymphadenopathies or any hepatosplenomegaly, no similar episodes in the past, no family history of bleeding, and this child is born out of non-consanguineous marriage. What is remarkable in the CBC is low hemoglobin and neutropenia. The differential, the neutrophil percentage is only 22. So the absolute neutrophil count is on the lower side, and the platelet count is 56,000, but the child is bleeding profusely. We can see the subconjunctival hemorrhage. This child had GI bleed, he had epistaxis. So the initial diagnosis was ITP. But what is unusual about this case is, the bleeding is disproportionate to the severity of thrombocytopenia. So bone marrow is warranted here. So we did the DIC profile of this child, keeping some malignant condition in mind. And we found that the coagulation profile was deranged and the fibrinogen was very low. So this is a condition, APML, that is acute promyelocytic leukemia, AML M3. AML does not have a very good prognosis like ALL. ALL, the survival is more than 90%, but AML, even in the best centers, it is around 50 to 60%. But this AML M3 has a survival of more than 90% if they are picked up early. But unfortunately, these cases succumb to intracranial bleed because most of the times they are labeled either as dengue or as ITP, because initially they present with absolutely normal count. Like in this child, the count was just 5,000. So they'll have thrombocytopenia and they might have anemia, and that anemia can be attributed to bleeding. So in such cases, in any case of dengue or ITP, if we see that bleeding is disproportionate to the platelet count, we must ask the pathologist to look at the peripheral smear. If the count is on the higher side, around 10,000, a good pathologist can pick up these promyelocytes on the peripheral smear itself. But if the count is low, like this case, then it may not be picked up on peripheral smear, and we have to go for bone marrow. So this child, as we can see here, OR rods and multiple hypergranular promyelocytes. So this child was a case of APML, and we have something known as differentiating therapy for APML. The child was put on that and he responded very well. But if we don't pick it up early, the problem here, the underlying pathophysiology here is massive fibrinolysis. The fibrin plug just cannot form. So they bleed like anything. Within no time, they develop intracranial bleed and succumb. So the initial 4 to 8 weeks of treatment will make or break the patient, and pediatricians play the most important role because they are the first point of contact as far as such patients are concerned. So coming to another case, this term AGA baby was who was admitted for phototherapy on day 3 of life to our NICU. A CBC was done which showed a platelet count of 22,000. But the other cell lines were absolutely normal. Now this child's mother CBC is also normal. We took a detailed history to find out if the mother has any autoimmune disease like SLE or ITP, but nothing as such. There was no significant antenatal problem as well. So what are the differentials? A well child with thrombocytopenia. So this was a case of neonatal alloimmune thrombocytopenia, which is the most common cause of low platelets in well-term infants. And this is also the most common cause of intracranial hemorrhage in term neonates. You mostly seen in the severity is maximum in first pregnancies, seen in otherwise healthy babies, and 20% of them can have antenatal bleed or bleeding immediately in the neonatal period. So as a student, I always used to get confused. What is this alloimmune thrombocytopenia? It's very easy to understand autoimmunity. Alloimmunity. So this is this condition, neonatal alloimmune thrombocytopenia, is very similar to RH incompatibility, like how in RH incompatibility the maternal and the fetal. So similarly like that. So here the fetus inherits platelet antigens HPA1A from the father, which is not there in the mother. So there will be transplacental passage of these fetal platelet antigens to the mother. Now mother does not have these antigens, so the mother identifies it as foreign, and the mother forms immunoglobulin antibodies against this particular antigen, and these antibodies, when they cross the placenta, it reacts with the fetal platelets and it completely destroys the fetal platelets, and that causes severe thrombocytopenia because the reticuloendothelial system will identify these antibody coated platelets just like ITP, and then the platelets will be destroyed, and hence it causes severe thrombocytopenia. So this is just like RH incompatibility of the platelets. So we have to be very aggressive when it comes to the management of NAIT, because again there is a risk of intracranial bleed. So the first and foremost thing is prompt recognition. We should not waste time in doing a lot of workup, and IVIG is very effective in more than 75% of the cases. The aim should be to maintain the platelet count of 30 to 50,000. Now the question is which platelet to give. So we have to make sure that we are giving a platelet which does not carry that particular antigen, HPA1A, which the fetus has inherited. So in foreign countries, they have special blood banks where they have HPA1A negative platelets, but that facility is not available in our country. So the best choice, if we desire an immediate rise in the platelet count, is to give the maternal platelets, because we are sure that mother is not having that particular antigen. So mother can be subjected to apheresis, and the mother's blood platelet, after it has been obtained by apheresis, just like STP preparation, it should be irradiated. Whenever we are giving any blood product from relative, we should always irradiate the blood product, otherwise it leads to a condition known as transfusion-associated graft versus host disease, where the risk of mortality is more than 90%. So if you are in a center where apheresis facility is available, subject the mother to apheresis, obtain her STPs, and subject it to irradiation and give it to the, within no time the platelet count will rise. This is life-saving, but these facilities are not available everywhere, so we can also go for random donor platelets. Manage especially after we have given a good dose of IVIG. RDPs would do the job. So manage aggressively for the first 2 weeks, because the chance of intracranial bleed is maximum in the first 2 weeks, because it takes around 15 to 20 days for the antibodies to completely clear out of the circulation. And we should do neurosonogram at the baseline. That's very important for counseling. And then weekly serial cranial USG at least for the first month. So just talking about platelet transfusion. So some of the do's and don'ts of platelet transfusion. Procure the platelets from the blood bank only prior to transfusion. Sometimes the platelet will be transported from a blood bank which is situated kilometers away. So platelets are viable only if they are constantly agitated. If the platelets are just kept like that, like how we keep blood on the bedside of the patient, it is useless. It is just, we are just giving water to the patient. So ideally we should have an agitator in our ward where the platelet should be constantly agitated. Most of us don't have that, so we can ask the parents to keep it shaking like this so that the platelets are viable, otherwise it's waste. Infuse the platelets immediately upon arrival to the hospital. Do not store platelet in hospital refrigerator. The ideal platelet should always be kept at room temperature, 22 degree. If it is kept in the fridge, it's not going to work. and begin with a slow infusion rate. Mostly we get reaction with SDP, but not with RDP. Infuse as rapidly as possible. It's not going to cause volume overload. And we make sure that you complete everything in 1 hour so that we don't lose the viability. And use platelets sparingly, treat the patient and not the platelet count. So this was a case of neonatal thrombocytopenia. So the causes, we saw a case of neonatal alloimmune thrombocytopenia, but we also come across neonatal autoimmune thrombocytopenia, which is very simple condition. In alloimmune thrombocytopenia, there's a risk of intracranial bleed, but autoimmune thrombocytopenia, just like ITP, we can be rest assured that the bleeding is highly unlikely. And in such cases, we usually get history of mother having ITP, mother having low platelet count, or mother having a condition like SLE, APLA, something like that. So their platelet transfusion is not indicated. Just assure, and within 2 weeks, the antibodies will clear up. Non-immune destruction can happen if the mother had preeclampsia, in asphyxia, sepsis, DIC, NEC, or congenital infection, as we all are aware of. Inherited causes, again in this belt of Maharashtra and Karnataka, it's quite common. We do come across conditions of Wiskott-Aldrich syndrome, so we should suspect this if the mean platelet volume is low, if the platelet size, if your pathologist says that he can notice that the platelets are very small in the peripheral smear. X-linked thrombocytopenia. There are so many conditions associated with large platelets like Bernard-Solier syndrome. We'll see the cases further. And neonatal onset malignancy, again, it's not very rare. We can see in neonatal onset neuroblastoma. Also infantile congenital leukemias or congenital HLH. These conditions should be kept in mind if the child has hepatosplenomegaly and thrombocytopenia, because the initial manifestation can be just isolated thrombocytopenia. Again, destruction or sequestration. This can be seen in thrombosis, Kazabak-Merit syndrome, where there's a large hemangioma in the liver, or even an external hemangioma for that matter. Autoimmune, hypersplenism, maybe due to storage disorder. Osteopetrosis, Dr. Mahesh Kore sir is here. He has, in the last 3-4 years, sir has seen at least 3-4 cases. We have, in last 7 years, I have a set of 18 cases. So it is not so rare again, osteopetrosis. So we must ask for an infantogram, a simple bedside investigation which can pick up these cases. So osteopetrosis, if you see this marble bone appearance, again the initial manifestation can be just thrombocytopenia along with some skeletal deformities. Then inborn errors of metabolism, especially methylmalonic acidemia, propionic acidemia. Storage disorders, especially like Hirsch's disease, glycogen storage disorders, the initial manifestation can be thrombocytopenia. Now, I'm not going into the details of all the congenital causes of thrombocytopenia, but we must remember the common ones.
Sorry to interrupt you, ma'am. Last 2 minutes, ma'am.
Can I take 5 more minutes? Okay. So I'll skip this in the interest of time. So this 6-year-old boy, born out of 3rd-degree consanguineous marriage, was referred to our center as a case of chronic refractory ITP. The first episode of bleeding was at the age of 4 months. He had repeated episodes of epistaxis and GI bleed and received multiple platelet and blood transfusion. He was treated with steroids, IVIG, and underwent splenectomy at the age of 5 years for refractory ITP, but the thrombocytopenia and bleeding persisted. Now, when he was referred to our center, his hemoglobin was 6.2, MCV was 62, which shows chronic iron deficiency anemia. In any condition where there is blood loss, we get chronic iron deficiency anemia. Platelet count was 42,000, but he was bleeding profusely, so unlikely to be ITP. Coagulation profile was normal. Bone marrow was normal. Iron staining of the marrow showed reduced iron stores, suggestive of chronic blood loss. Now this is the peripheral smear. What we can see here is the giant platelets, which is almost of the size of the lymphocytes. So this was a case of Bernard-Solier syndrome. So what is the defect? As I mentioned in the first slide, the platelet glycoprotein receptors, GP1B9 was defective here. So this was a case of Bernard-Solier syndrome. Another case, this 3-year-old boy born out of 2nd-degree consanguineous marriage presented with repeated bleeding manifestations in the form of epistaxis and multiple skin bleeds since the age of 3 months. Now this child was evaluated extensively at Bangalore, Narayana Health City, and he was labeled as the case of ITP after the bone marrow evaluation. In neonates, the bone marrow is really challenging in small children. Sometimes we don't get the correct diagnosis. So this child had received multiple immunomodulators and immunosuppressive agents, which included prolonged administration of steroids for over 6 months, azathioprine, mycophenolate, mofetil, rituximab, but the child continued to bleed, and at the age of 3 years, he had severe bleeding. Along with that, he also complained of repeated episodes of otitis media and 2 episodes of pneumonia. So initially, these manifestations were attributed to immunosuppression due to drug received, but the bleeding manifestations worsened. So we decided to reevaluate our center. Now, the platelet indices didn't support the diagnosis of ITP. In ITP, we get large platelets, high MPV. This fellow had low MPV and low immature platelet fraction, and even the bone marrow did not show megakaryocytosis, as we can see here. So we did his immunoglobulin levels. We could not do the IgE level as the sample was less. So only the IgM was on the lower side, rest were normal. But what was striking was this MPV of just 4.8. So this is how a normal platelet looks, and this is the small platelet. So can anyone tell me what is this? Exactly. So this is Wiskott-Aldrich syndrome. So we did the genetic test, and that did come positive for Wiskott-Aldrich syndrome. So immunodeficiency is an evolving disease. We should not always expect that the child should have the typical triad of thrombocytopenia, eczema, recurrent infection. These conditions can evolve. The initial manifestation can be just eczema, just thrombocytopenia. So till 3 years, the child didn't have recurrent infections. So we have to have a high index of suspicion, and peripheral smear is very important. I think I'll skip this case. This was a case of common variable. This was initially labeled as ITP at the age of 3 years. Till the age of 16 years, the child was like a chronic ITP. When he presented with intracranial bleed, was referred to me for the evaluation of refractory thrombocytopenia. So I decided to do the workup for the secondary causes of thrombocytopenia, the huge list which I mentioned. So we did the ANA, HIV, H. pylori, everything was negative. Then we did immunoglobulin levels, and we found that all the immunoglobulin levels were low, and when we did the lymphocyte subset analysis, the B cell subset was normal. So this was a case of common variable immunodeficiency. So CVID can also present with thrombocytopenia. I have a couple of cases of CVID which presented only with autoimmune thrombocytopenia, diagnosed at the age of 18 years. So just 2 more cases. So this 4-year-old female born out of consanguineous marriage presented with bleeding manifestation in the form of skin bleeds. She was labeled as a case of ITP after bone marrow evaluation, initially treated with steroids, to which she showed very good response. And she was completely asymptomatic for 1 year, absolutely no bleeding. Now at the age of 5 years, she presented with anemia, thrombocytopenia. She had generalized lymphadenopathy, as we can see here, the cervical lymphadenopathy, and also hepatosplenomegaly. Now this is her CBC. This is a hemolytic anemia. Coombs test is positive, and the platelet count is also low. So everything is suggestive of autoimmune hemolytic anemia plus thrombocytopenia, what we say EVAN syndrome. But EVAN syndrome is a diagnosis of exclusion. So what was this? So in view of lymphadenopathy, we considered a diagnosis of autoimmune lymphoproliferative syndrome. We did a lymph node biopsy, but we didn't get any clue there. So we did all the, evaluated for all the supportive criteria, like immunoglobulin and this thing, and that gave us the diagnosis. We also did PET scan to rule out lymphoma, but that was negative. So this is the clinical criteria for the diagnosis of ALPS. I'll not go into the details of it. So our child fulfilled the required criteria, that is chronic non-malignant, non-infectious lymphadenopathy and splenomegaly, and elevated double negative T cells. So we did this double negative T cells. It is done at NIH free of cost, and this was a case of ALPS. We could not do the genetic test in this child, but we put the child on sirolimus. They do very well with sirolimus. His autoimmune anemia, thrombocytopenia, everything has resolved, and child is doing well. But they are prone to develop lymphoma, so we have to screen them every year with PET scan for lymphoma. So that we are doing that. So this 5-year-old girl presented with epistaxis requiring packing, repeated episodes of epistaxis. Similar episodes 2 times in the past. She had few purpuric patches, no lymphadenopathy or organomegaly. Hemoglobin is normal, the platelet count is just 20,000, and WBC count is normal. So what we can see here is the platelet clumps. So this is a case of von Willebrand disease. So as I mentioned in the first slide, platelets and von Willebrand factor have a very important interaction. So there are 2 types of von Willebrand disease where we can get severe thrombocytopenia. One is type 2B von Willebrand disease, where the von Willebrand binding with the binds excessively. There's gain of function mutation. Von Willebrand factor binds excessively with the platelets, and all the platelets are cleared from the circulation. There's no problem with the platelet, but due to hyperactivity of the von Willebrand factor. And there's another type of von Willebrand disease, which is platelet type von Willebrand disease. So there the problem is in the platelet receptors. Again, gain of function mutation in the platelet receptors. They bind excessively with von Willebrand factor and they are cleared from the circulation. So when we should suspect that this thrombocytopenia is due to von Willebrand disease, when we get a history of menorrhagia. This is a small kid, but they usually present with menorrhagia, or there will be some history in the family, maternal or aunt, somebody having menorrhagia in the family. PT-APTT baby absolutely normal. So the last case, this 9-month-old girl, she presented with mild skin bruising, mild pallor, no organomegaly. There's mild anemia, microcytic anemia, WBC count is normal, platelet count is 23,000. Peripheral blood smear shows thrombocytopenia, and these are large platelets. Now bone marrow is consistent with increased peripheral destruction. So the child was diagnosed as ITP. Everything is looking like ITP. The child was given steroids, IVIG, platelet transfusion, and after all this, after giving this transfusion, platelet transfusion, the platelet count did increase to 50,000, which we don't see in ITP. It doesn't improve with platelet transfusion. Now 1 month later, her hemoglobin dropped down to 8.5, WBC count is normal, and the platelet count has further dropped down to 14,000. So what are the possibilities? So what we can see here, these are cystocytes, lot of fragmented cells. So we did this ADAM-TS13 activity, which was positive. So this is a case of TTP. Congenital TTP, we do see acquired TTP also, but in the pediatric age group, we see more of congenital TTP. So in congenital TTP, the treatment is fresh frozen plasma, which has this ADAM-TS protein. So we have to, every 3 weekly, we have to give fresh frozen plasma. Now why in this child with platelet transfusion the platelet increased is because even the SDP or the RDP contains some plasma, so that plasma had had ADAM-TS protein, so that's why the child's condition improved. So we have to have a high index of suspicion if in the peripheral smear we are getting these cystocytes, fragmented cells, and if the LDH is high. So the hallmark is very high LDH in congenital TTP. Thank you. So to conclude, we have to keep these 2 contraindications for platelet transfusion in mind. One is the condition which I just presented, that is thrombotic thrombocytopenic purpura and heparin-induced thrombocytopenia. If you are transfusing platelet in these conditions, it is like adding fuel to the fire. Thank you.
Thank you, Abhilasha. On behalf of KAP, you have simplified, but it's a long one. Thank you.
Thank you, ma'am. Thank you, chairpersons. I request all the dignitaries to proceed to the felicitation area. Moving on to the next session, which is how to deal with pediatric emergencies in office practice. This will be, the speaker for this session is Dr. Vinayak Patki, sir, and the chairpersons for this session will be Dr. Pratibha Khare, ma'am, and Dr. Snehal Patil, ma'am. Dr. Pratibha Khare ma'am is the senior most eminent practicing pediatrician in Kolhapur, and Dr. Snehal Patil ma'am is practicing as pediatric intensivist in Kolhapur.
Opportunity to introduce Dr. Vinayak Patki from Sangli. He is a director of neonatal and pediatric intensive care services and ECMO program. He is head of the Department of Pediatrics in Ushakkal Abhinav Institute of Medical Sciences, Sangli. So over to Dr. Patki, sir.
Thank you, ma'am, for kind introduction. Greetings from my hospital. This is Ushakkal Abhinav Institute of Medical Science. What I'm going to deal with next 30 minutes is how to deal pediatric emergencies in office practice. So emergency is defined as potentially life-threatening situation, usually occurring suddenly or unexpectedly. It can occur anytime socially, and we have seen so many emergencies in our pediatric practice. And the next important is disaster. Though it is a significant demands of crisis on a mass scale, but if you don't tackle the emergency, you can lead into disaster. And difference between the level of emergency and disaster is the response. Are you prepared for that or not? And it is said that by failing to prepare, you are preparing to fail, by Benjamin Franklin. So lot of emergencies we tackle in pediatric office practice, like from respiratory distress, severe asthma, shock, anaphylaxis, convulsive seizure, and so many things. And important, so many things are there. Some unusual things can also happen, like transport of a sick child, and sometimes breaking bad news itself can be an emergency in your office practice. So can you escape from emergency? If you say, no, I am doing only OPD practice, can I escape from OPD emergencies? No. The reason is, first is medical ethics. Your medical ethics doesn't allow you to go away from shedding your responsibility of going away from managing emergencies. And other is law. So see, this Article 21 of Constitution says that stabilize first. So it is irrespective of your monetary benefit, infrastructure restraints and all that, it is your duty, legally also and morally also, to manage emergencies. So this is our routine scene. Now it is July, August, September. This will be more worse in our all OPDs. And this busy pediatrician sitting, some pediatrician sitting in the chair is not knowing what is happening outside. And so many things are happening outside and can lead to emergency, and if not prepared, can lead to disaster for you. So all these videos, this is a disclaimer, has been taken with consent, and we try to hide the identity of the patient. So what I'm going to focus in next 25 minutes is, I'm going to look at three things. One is preparedness, another is approach, and how we are going to preparedness and approach into implementation. On my first talk, all will depend on these three things. So let's start with preparedness. So first and foremost, all of us, you have to ask yourself, are you prepared yourself adequately to manage pediatric emergencies? And to code this is a 2021 pediatrics code. This is from US. See, that's from 15 centers, multi-centric trial, and it says that pediatric office preparedness in US also is suboptimal in a multi-centric trial. Just imagine about India, so many things. So we are not adequately prepared. So I'm going to these are the 4, 5, 6 areas where we can see our preparedness and we can check ourselves also. All of us introspectively, those who are only managing as a daycare or OPD thing. First and foremost is yourself. Are you yourself are ready to manage emergency? So that's why you should know your environment, staff, equipment. You yourself keep mentally prepared, manage your human resources, know your limitation. This is very important. And last but not least is updating knowledge. Indian Academy of Pediatrics and all chapters are updating all pediatricians across India about updating the knowledge. So a lot of skills, IIP, BLS, ALS, essentials course, intensive care chapter, BPICC, so many courses are there which are giving you and updating your provided skills about updating yourself or preparing yourself. Then all you should have a small SOPs on your one-page SOP of managing, like BLS, this bradycardia, shock, anaphylaxis, decay, wheezing, epiglottitis. So many things are there. You should have one-page SOP with you. So this kind of case comes to your OPD, what you are going to do. And this you can put it like visual aid in your OPDs or outside, like how you manage bradycardia, how you can. These are all PALs available all with all of us. Next is, you cannot do things alone. This important thing is your team. And what is your team in office practice? Your receptionist, your mama, moshi, whatever, helper, and some maybe secretary which can call. So focus from receptionist to assistants. You have specific role allocation should be there. You should know the rescue team, logistic responsibility, who is going to take care of equipments, protocol, how you are going to communicate, and last but not least is your team also needs to be parented information. EMS is still very scattered in India, so you cannot remain so much dependent on EMS like other countries. Just any emergency, start resuscitating and call EMS, 5 minutes, person will come and take the thing. It is not going to happen. So you have to make your things. So you have to keep your train the team that such and such patient in your busy OPDs, these are the red flags. You have to explain team, and that person will recognize and start giving the priority to allow them to see you in OPD, or allow him to put it into the indoor facility. Then their response team is there. 108 is quite nice now, and you should know a lot of numbers to your nearing hospitals, nearing ICUs, and your colleagues for help. Whether you can do contingency plans are there, then what is nurse is going to do, what helper is going to do, what your secretary is going to do, either activating plan, calling people, and all those things. So you have to know, you should prepare your response team. Next is staff training. How you are going to try? Most of us, we usually have BHMS and BMS fellows with us. So at least try to take BLS training for them. All medical staff should have PALS training. Determine the skill level of newly employed medical staff, supplement certificate and recertification, and keep on training them. So one time spot training is not going to help. You have to train them recurrently and just see them whether your team is adequately prepared to manage the emergency. Next important thing is equipments. So these equipments, IMSO app, this is a mnemonic what we use for resuscitation. I for IV fluids, cannula and intraosseous needle, M for monitor BP, pulse ox, S for suction, O for oxygen, A for airway equipments, P for pharmacy, and last P is very important, that is personal. So you may or may not have this kind of emergency, but equipments, all equipments you should have. This is a very easy thing what we follow from the Braslo-Luptin set. It is available with Amazon at hardly cost 1,600 rupees and all. Just it is a tape. Just put the tape from head end to look from the toe and see what is the height in what color code your system goes. So if you got in green, just see it, just read on that, prepare everything ready. There is no need to check books and all that. What endotracheal tube, what kind of suction catheter, what kind of LMA, everything is available. And these are, if you buy this system also, you can have drawer. So just open that drawer, what is color code, and you start managing the things. Life becomes very easy for you. Then location of the equipments, where pre-stocks are there and equipment boxes. Like this is, you can do this kind of things, like Caesar box, anaphylaxis box, then shock box. These kind of things you prepare, just open that thing, just the tube, and start treating the patient. So a very important thing about equipment, it should be routinely checked, restocked and readily available. And all of your staff teams should know where things are there. Everything is there, but newly appointed staff, it doesn't know, then it can become problem. So just few words about two important equipments. One is airway equipment and another is your shock or circulation equipment. Oxygen flow, your mask, reservoir, NRM mask and all that things are there, but very important thing is LMA. LMA is laryngeal mask airways, very much underutilized in our country. So start using LMA, it is a life-saving, even if your trained assistant can also give a life-saving to that advanced airway. And last but not least is a cricothyroidotomy. When you can come in a situation where you neither intubate nor able to ventilate in that situation, simple 14 gauge needle, catheter, 3 mm adapter and 5 ml syringe can save you. I come across two emergencies. If things would have been not there, patient would have died. And no expert, even if it is trained in whatever capacity, cannot able to tackle this situation if these simple equipments are not there. Fluid all should have intraosseous needle. Don't try to waste more than 90 seconds in putting the IVs, even if you are expert. There's no point, there's no feeling shame on, in this situation, I'm not able to get peripheral IV, straight away go for intraosseous lines. Ringer lactate, preferable solution, 10% dextrose in cases of hypoglycemia. Pulse ox has become part and parcel of life. Glucometer has become part and parcel of life. Nebulizer and MDI, these things are, and optionally, and now as per Bombay Nursing Home Act or NABH is concerned, defibrillator is also necessary. All of us now, we have defibrillator and ECG portable monitors, all of it with us. After equipment, medications. So we have enough stock of medications, but please check the expiry. In some situations, if you don't manage the emergency for prolonged time, sometimes these drugs get expired, and sometimes, unfortunately, you can able to land up this in problems. So you know all this adrenaline, atropine, this is a standard drugs which you should have available in enough stock and enough strengths, and your staff should know how to dilute, how to use it. Next, last but two important things is there is documentation. Whenever you are getting emergency or your adrenals are very high, child is going to die or not, and that time you are very poorly in documentation. And most of the medical legal cases happen because of poor documentation. You should have your CCTV coverage whenever you are doing resuscitation. This is a good proof. Sometimes you can ask your assistant to get mobile and start recording it. Stress and documentation is must for all events. And what you should document: date, time, record stabilization attempt, medication doses, fluid volume, consultation opted, patient condition. That means each and everything you have to document. One person should be there to document. You cannot do everything alone. You are the leader, you can ask your team allocation, but one person should be there to document, and this is very important. And last but not least is mock drill. But nobody can go and start singing like Lata Mangeshkar with one dice. Nobody can go and start hitting his centuries like Virat if you are just not practice. This practice makes the man perfect, and this is how you are going to do. You have to create a mock situation, and this is best way to ensure is simulation-based. Mock training is there. You have to critique action plans and try to do the scavenger hunt. This concept is called as identify equipments and medication needs. What thing has gone wrong with your mock drill? This is a simple mock drill. I'm not going to go this video, but these videos are there in your YouTube everywhere. See, try to create these scenarios and see whether your system is ready to cop up this kind of situation. So how you are going to do, prepare, just involve all members of the office, schedule a team of regular interval, represent the priorities, evaluate the code, and make changes. And after that, you are going to be a moderator. See so many things you have to observe during the first mock code. Everything can go wrong when you are managing a first mock code. Try to observe clinically what person has done, which thing clinically correct, and other thing is organizationally. Whether your team members have done their job properly or not. Clinically, that means whether you have done put IV, whether he has given intralorazepam, all these are. So you have to observe these things, and then what you have to do is a debriefing. Debriefing is something called as what things had happened. After the things, you have to ask all these W's: where, when, why, who, what, and how. Important thing is last, which is a burst, is why. Any event when it happens, why, you try to answer those why, and if you go to the bottom level of why, you try to improve yourself. This and these things has improved. After coming from preparedness, now I am going to approach. This is pediatric emergency. All of us, we have gone for BLS, PLS, IAPLS, and so many things. I'm going to switch that thing to a direct approach. You may or may not have gone through this approach, but what is approach is detection, then detection, intervention, then reassessment, effective communication, and transport. Every emergency you have to go through this direct approach. So let's see what is the detection is, what is the physiological status, what could be the diagnosis. Interventions, whatever interventions you do, that is immediate life-saving strategies. Then reassessment is whether whatever intervention you have done is effective, or whether it has developed new issues. Then effective communication in between your team members and communication with your family. And last but not least is the transport. When you talk about office practice, most of the 90% of the emergencies you have to send to your near ICUs or better facilities, and in that case, the transport is very, very important. So next, just see how detection is there. I'm not going to detail because all of us, we are well versed with PALS, but let's see things are. So general or initial assessment, then primary assessment, your Pentagon, sample is your secondary thing, and laboratory studies like tertiary. In the initial assessment, ABC, or you can call it the CBC, appearance is replaced by consciousness, and why we are doing this initial assessment is what you are going to differentiate at moment spot is whether this is a life-threatening condition is there, or whether it is going to require a routine care. This first spot impression you have to create about initial assessment. What do you mean by life-threatening condition about all these things? Is unresponsive, inconsolable irritability is there, respiratory failure, breathing, apnea, and last is cyanose or pale color or mottling. Any of these things are there, that means the child is in life-threatening emergency and you have to act fast. This is a real emergency. Yes, then primary assessment, airway, will go in details of one by one. So first and foremost important thing is airway. Airways, just try to answer 3 questions, whether end is clear, maintainable, and not maintainable, or it is complete or partial airway obstruction. This is some videos are there. This is about stridor. This is again a life-threatening emergency. Next is, this is about airway emergency of asthma. Then coming to the breathing. Rate and efforts of breathing are important, and again important thing is abnormal sounds. So what you are expecting here is whether patient is apnea, bradypnea, or significant work of breathing. Apnea and bradypnea comes later, all of us we know, and if we don't tackle the respiratory effort distress, finally or eventually you are going to land in either apnea or bradypnea. So this is a case with grunting intervention and SPO to 94. See the this is a grunting. If this child is not done treated immediately, he's going to have a apnea or bradypnea over next few minutes. Then this is a severe respiratory distress. Here this person is holding in office practice is just holding in a just some airway, oxygen. It's not going to help. He needs a better support, HFNC and CPAP. A word about HFNC, low cost equipment, but is life-saving. Most of now your intubations and invasive, non-invasive ventilations have come drastically because timely escalation from your head box or face mask from HRM to HFNC. So it is not going 3.5 lakh rupees is the best time investment in even if your OPD, 1-2 patients, 3 patients you manage, you can able to save life, and it's not that costing your economics also. Then this is, here your HFNC is not going to work. See this child, this is almost is a lethargic, he is not active, lame. And even if whatever oxygen you are going to put, these children will have, may or may not have hypoxia, please remember. They can remain 94, 93, they are just limp. If you don't attempt, don't intervene them, they are going to die immediately. They will have apnea, cardiac arrest, and then your whatever amount you do about CPR, they are not going to improve. So there is no role of, and last category is very important, you don't forget this transient, just effortless tachypnea. This kind of effortless tachypnea is there in sometimes in a metabolic cause, and this is sometimes acidosis. Your diabetic ketoacidosis. Sometimes they are otherwise just they are breathing. If facilities are there, you can do, and if patient don't have distress, they can have this kind of acidotic breathing, and here also your intubation in CPAP is not going to treat the thing. Next important parameter is circulation. Heart rate, capillary fill time, skin and blood pressure. Blood pressure comes last, so don't try to focus on blood pressure because shock per definition is not at all related to the blood pressure. So blood pressure, hypotension becomes last, and when you are getting the child with hypotension, you are likely to land yourself or not treated properly into the disaster. So what you are going to do for this? This is a distal pulses. We are well versed with central pulses. Try to put palpate, brachial, and carotid and femoral. Don't try to go for radials, and capillary filling time is all of us we know. Coming to after these two important things are disability, GCS, yes, complicated. All of us we know this is very difficult to remember. APVU is easy to remember. Now different scales have come, and exposure is very important. We are next few cases we are going to see about exposure, how it is going to happen is with hypothermia, bleeding, petechiae, purpura, abdominal distension. So lot of these things are you are going to focus after stabilizing this ABC. Secondary assessment. So history per se is very, very important for once the patient is stable. But before that, you have to do this, tackle these life-threatening situations, and then you are going to do for S for signs and symptoms, allergies, medications, what things have past medical history, last meal, and events leading to these presentations. So this kind of sample histories your assistant should take when you should not try to take what has happened, any injection you are taken when child is having bradycardia. Now, we have seen this. We have seen when you are managing emergencies and all that, we are not knowing which things should be given priority, and that's why sometimes we get fumble. We try to give unnecessary time and waste to the things which are not important that particular time. Tertiary assessment, maybe non-laboratory and laboratory, it goes against. Most of the things are not available in your office practice except for pulse oximeter and max for chest X-ray. CT, ECG, EEG is not with maybe and may not be with you, and except for VBG, I word about VBGs. Even if you are not able to take ABG, just take sample in heparinase saline and send it for VBG. Now most of the machines except for PO2, rest of the things you can able to appreciate. And now new ABG machines give you sodium, potassium, lactate, hemoglobin, and everything. That means simple one VBG can give you a lot of information about your patient. Interventions we have already discussed. So what you are going to allow position of common mistake, what we do is we try to force our ideas on the patient. What a child is crying, breathless and all that, you try to put on the bed and try, see he's going to be comfortable in his mother's lap, what your comfortable position is there, give that position. Head positioning and suctioning, do proper simple maneuvers like head tilt, chin lift maneuver, and if child is, we'll discuss that our jaw thrust is when the child, any time history of fall, don't try to do head tilt, chin lift maneuver because you are going to damage the cervical spine. Inserting, if child is unconscious totally, go for oral airway. Child is crying, don't try to push somebody else. Usually it happens with PGs, unconscious, try to put gag reflex, vomits, and again respiration, and child succumbs in front of you, which would not have been there if you had not intervened those oropharyngeal airways. As I told, LMA, try to using LMAs are not that costly, 800, 900 rupees LMAs, and it can save, and even if you cannot able to intubate in this kind of situation, you can put LMA in a try to take help of your colleagues from your PICU and all that, and try to use LMAs. Circulation, as I told, whenever child comes with shock, first priority is before starting IV fluid and all that, put 100% oxygen with HRF. Whatever shock is, you are going to deal with oxygen delivery and not, so that is your first priority. Then assisted ventilation and advanced airway and all these things are there as part of circulation also. Defibrillation should be there. SVT is the most common. Fortunately, we don't tackle so many cardiac emergencies with us, and that's why we are lucky, not like adults, like MI blocks, ventricular fibrillations and all that. It's very easy for us. We are most of the times, 80% of the cause is respiratory, try to tackle that thing. Word about resuscitation in shock, because these things are visually at all national levels, we try to give this message about advanced or cervical sepsis guidelines 2021. So what it does is, whenever you get shock, try to 1 hour of recognition and 3 hours for initial suspicion. From this timeline is important. So accept uptime IV access whenever child with shock, try to take culture, empiric antibiotic therapy. Whenever you have history of something, fever, and child has over the period of time, this is very, very important. If possible, that's why I told about VBG and lactate, most of the machine they do. And coming to the then giving IV fluids. Push and pull method is outdated, so don't try to push and pull method, at least in your OPD when you don't have PICU setup. Your first try 20 cc per kg, sometimes crash the child if a child is coming to with just tachypnea and cardiogenic shock. So that method is gone now. So what I said, this is a very, very simple. If you don't work in intensive care setups, two important things are there. Whenever abnormal perfusion without hypotension, no fluid bolus. Abnormal perfusion with hypotension, 10 to 15 ml over 20-30 minutes. So this push-pull method, unless and this is gone, it has created so many problems, unnecessary. You go on creating problem related to pulmonary edema and other things. Yes, if you have PICU, you can use first bolus 10 to 20 ml over 20 minutes. Wait, see the things are, how things are, whether child is fluid responsive or not, and then try to give next bolus. Definitions for shock: SBP less than 50 for less than 12 months, SBP more less than 60 to 1 to 5 years, and systolic blood pressure less than 70 for any when above 5 years. So again, next thing is after giving what? Dopamine. So dopamine is outdated. So don't try to use dopamine. So these are enough data. I cannot explain all these things on. We have enough literature now. What dopamine does, you can ask me. I'm using dopamine for 20 years. Nothing has happened. Nothing has happened for that particular patients. How much patients you have data. So problem is they have increased chances of arrhythmia, they have increased chances of mortality, they have increased chances of hospital-acquired infections when you compare either dopamine with adrenaline or dopamine with noradrenaline. So what you can do? You are given 10-20 ml of per kg bolus slowly over 20 minutes, patient not improving, you are calling for help, your team is ready, ambulance is coming, what you are going to do? You are going to start a low dose adrenaline. That low dose adrenaline is much preferred as compared to your dopamine. So what do you mean by low dose adrenaline? Is epinephrine 0.05 to 0.2 microgram per kg per minute. Same is applicable for noradrenaline, but noradrenaline we are not giving as a mass scale from this dice. Important thing is epinephrine. Most of the children shock are coming as a cold shock, though cold and warm shock concept is going, or next 1-2 years that cold shock concept is already gone. So this is not the scope to discuss all these things, but important question is, first bolus start low dose norepinephrine safely given through any peripheral line for 1 to 2 hours, within which time you can reach your PICU and patient can get central line next kind of treatment. So that message I want to highlight. Coming to the secondary assessment, tertiary. So secondary assessment comes with assisted ventilation, antibiotics, neuroprotective measures like 3% NS and all those things. Next is Reassessment after each action, you try to see whether things had improved or not, whether new issues are developed or not. And then comes to effective communication. Communication, 70% of the errors are due to the faulty communication. This is data from US, and when this data came, all of were horrified how this thing can happen. Second cause of problem is you are due to error, and you have to improve the teamwork. And last but not least is the transport. So advanced preparation should be there, coordinate with receiving facility, communicate with family, stabilize the child and anticipate requirement. So stabilize it is not a full stabilization, you have to go for a partial stabilization. Last part of my lecture will be case-based implications. I'm trying to discuss 5 cases, one related to each system, and try to see whatever knowledge what we have adapted from our direct approach and preparedness, how we can implement on those particular cases. So case 1, 4-month-old baby presents with cough, colds, 4 days, treated on the antibiotics and this is the child. So what is happening? In the detection, this is a life-threatening condition, respiratory distress, this is pneumonia. Okay, sorry. So maintain the airway, start NRM, IV access is there. In the reassessment, what you are going to do is call for help, see the monitoring heart rate, if anything is improving or not, and then go for. So next part is case 2. This is 13-month-old boy, represents with fever, cough, and cold for 5 days. And see this. This is all of us who know this is a shock, septic shock kind of thing. Same principles what we are going to affect here. We are going to reassess, do communication, and this child needs to be transported over the period of time, because child is not your. If you keep this child for more than half an hour, 1 hour, the golden minutes you are going to lose. These things are on our routine day-to-day practice. That's why I'm going fast, because I think time constraint is also there. So 5-month child vomiting for 5 days, not responding properly, and this is the video. So what here is his posturing. So this is a child with encephalitis and coming with shock. Word about stabilization here is a 3% NS versus mannitol. Whenever child comes with 3%, whenever child comes with shock and all, in this kind of meningoencephalitis or status epilepticus, don't try to give mannitol, because that will create more shock for you and more detrimental, and your cerebral perfusion pressures will go down. In those cases, 3% NS 5 ml per kg bolus over half hour, and then start drip of 1 ml per kg. Next case, this is so we'll spend some time on this. This is a 6-year-old child hit by a speeding car accident, loss of consciousness, bleeding, and he was brought by ITO. This is again a very rare, sometimes you can get this in a office practice also. Here managing emergency is slightly different from how you manage respiratory distress, shock, or unconscious child. This is slightly, why it is different is trauma here you are detected, and assessing trauma is something different. Here the role of assessing trauma is a manual inline stabilization. So this how you can, there are a lot of videos are there on YouTube. We have our IAP team has also developed videos and all. Even if it is not there with you, you can put sandbags and try to wrap it on this and this part and try to shift with these sandbags and necks so that cervical spine stabilization is there. Here ABCD is slightly different. Here A is with cervical spine, breathing with ventilatory support, circulation with hemorrhage control, very, very important. Try to put post bandage and don't try to forget giving tranexamic acid through IV. Whenever child is profusely bleeding, a child coming with trauma, you are trying to give, even in spite before getting the blood and all that, trying to try with your tranexamic acid. That helps, and it is a well-proven therapy now of giving IV tranexamic acid, 3 to 4 boluses you can use. Then next disability here, your important thing is a secondary insult. You are trying to prevent the secondary insult. Patient of head injury don't die because of per se head injury. This is, take my line, they die because of secondary insult. Secondary insult because of hypotension, hypothermia, hyponatremia, hypoglycemia, and all those. What is your aim is to prevent those 5-4, 5H and the secondary insult. Then exposure is with temperature control. Secondary service bit difficult. You try to see the patient from back, and all most of the times you are injured something related to the back which I may not able to see. And this is the how you. It's a bit busy slide about look, feel, hear, interpret, and intervene. So this how trauma is slightly different. So try your aim is in cases of trauma you try to do the primary survey, stabilize the patient, and with cervical spine stabilization, shift that patient. Last part, so this is how you do this, ABCD, and this is how the leader should be. In all emergencies, this is why one thing, leader should be standing there. Leader should not be fiddling with IV, that means you yourself should not be fiddling with all this, whether I'm giving adrenaline, whether I'm doing, he should be standing and watching the things, and he's trying to coordinating with the team. So here he's assigning the role and all that. Pals does good things about all these. Effective communication should be there between your team and all, and last is transport, which we have already discussed. Very rarely you come across a breaking a bad news in your OPD. Usually we have our own classes of simulation program called as IAP TRIPS training in pediatric emergency. Here we spend 2-3 hours on teaching how you should disclose a breaking bad news. Here I'm not going to detail, I'm just sensitizing you that this is something an emergency can happen. Something child has come to you, child is arrested, you are breaking that bad news, how you are going to, there is a systematic way. You can't do in just corridor and you are on the phone and say, yeah, aapka bachcha kuch nahi raha, leke jao. Next moment, you are going to have a people, 50-60 people in your OPD practice standing outside you and creating havoc situation there. So why it is important, it is a very sensitive issue for that family, very sensitive issue for you also, for your reputation also. So there is an important thing is, are they best way? There are multiple ways of doing, putting the breaking bad news. Just I am putting this one protocol, this is spikes protocol. What you mean by S is setting the scene. Don't try to, I think I have 2 minutes there. So don't try to just take them in a calm room, sit there with the patient, they are in a very panic state, sit them, ask them to sit, create a, setting up the scene is a very important. P is parents' perception. Ask parent what they have perceived. So what they have idea about what they, sometimes they see my child was coughing, grandmother was giving something and child may have fever. And now child is arrested and brought in front. She was contributing to something else, but child had something else. And now you are saying, no, your child has cardiomegaly and has died because of myocarditis. Things are not matching. So parents' perception is very, very important. Next part is I. This I is obtaining invitation. So try to get in. So don't try to bombard all of your information on the parents. Try to get intimation. Yes, what do you feel? What things has gone wrong? So what things, so they will start speaking something. They may be in a crying stage. They may be in a horrible stage of annoyed stage. They may be a Google parent. They may be knowing a lot of things more than you. They may be illiterate parent in a denial mode totally. No, मेरा बच्चा तो अच्छा है, अभी कैसा होगा? You are explaining death to them and he is asking, कब मैं बच्चे को लेके जा सकता हूँ? This is not the way. So you are trying to obtaining the invitation. Then next, giving knowledge. This comes fourth. Giving knowledge, we are ready to give knowledge at first. Your child has myocarditis, is died because of congestive cardiac failure. This comes last. Giving knowledge after obtaining invitation, and knowledge should be given the way they are perceiving. They know what things are known to them. Is very important thing is emotions and empathy. You should do it in a very emotional, empathetic way, and that's why we are lacking. It is very blunt statement from me, and it is very, but we are in a so much busy thing that we lose our emotions and empathy. We try to say, nahi, bradycardia tha, usko heart rate nahi tha, because somebody is calling you from home, you are busy, OPD is there outside, you have a lot of patients to see. You may have a lot of responsibilities, but in that case, you don't try to compromise your emotions and empathy. That is very important. If you do this part, very importantly, emotions and empathy, most of the times your effective communication, breaking bad news are tackled. And last is strategy and summarize. So most of the strategies, except for in death situations, you want to show now this is something that happened. It may be a child condition, it may be a hospital condition, it may be anything, but what you are going to do next, how you are going to arrange other things, how you are going to arrange transport, how you are going to arrange other facilities, any surgical intervention is required, and what are the chances of this child to get out from this situation. So this spikes protocol, if we follow properly, it is most of the times breaking bad situation, we can handle it effectively. How effective you are a good communicator depends on, even if in spite of good settings and doing all these things correctly, you can land up in problem. So to summarize, so this is emergencies, just maybe 7, 8 points are there. It is not necessary, it is only for medical emergency, and this stands for any emergency. Any kind of emergency, you can apply this principle, and this is called as CRM principle, that is Crisis Resource Management Principles. If you read this, these are applicable for any emergency in your life. So what is that? Call for help early, anticipate and plan, know environment, use all available information, whatever is with you, allocate attention wisely, mobilize the resources, use cognitive aids, communicate effectively, distribute the workload, and establish the role clarity. Either in a one-by-one manner or in a combined manner. These things are going to help in all kind of emergency. So thank you very much for your patient listening. So message is plan, prepare, and practice. So thank you very much for opportunity for giving me and talking on this subject of dealing emergencies in office practice. Thank you very much.
Please to proceed to the felicitation area. Moving on to the next session. De-addiction of the screen time, case-based scenarios, which will be given by Dr. Yatesh Pujar sir and will be chaired by Dr. L.S. Patil sir, who is a senior pediatrician from Kolhapur, and Dr. Kashmiri ma'am, who is a renowned pediatrician practicing in Itzalkaranji, who has great interest in adolescent medicine.
Welcome, Pujar sir. Dr. Yatesh Pujar sir is consulting pediatrician. Especially he is specialized in the adolescent medicine, practicing in Dr. B.M. Patil Medical College, Bijapur, Karnataka. Over to sir.
Good afternoon, everyone. I thank the Kapcon 24 team, my friend Dr. Mahesh Kore, Dr. Rahul Patil for giving this opportunity to come and talk on this important topic where almost all of us, doctors, parents are getting involved in this. This is a brief about my introduction. This is a famous saying. The difference between technology and slavery is that slaves are fully aware that they are not free. That's what is happening to us now. So this is a famous book which was written by Neerayal, how to get the customer hooked, how to get the seer, whoever is in the social media, how to get him hooked to the screens. And after that he realized his mistake. He wrote another book, how to become indestructible. So screen addiction is a form of a behavioral addiction. And behavioral addictions are constituted by an excessive, uncontrollable, repeated behavior leading to a significant harm and distress. So let us go to the case history, how our brain and media works together. Tanya is a HSC first year student who uses mobile for her studies and entertainment. She is active on social media to keep in touch with her friends. She likes to receive and send messages, short videos and photos to her friends. She feels sad when she does not get many likes. And this is a story with most of us. Okay, we want to get more likes and more appreciation from everybody. This happens to everybody, more so to an adolescent. So this is because of the reward center, which is around the medial forebrain bundle, and nucleus accumbens and ventral tegmental area are the main parts of this reward center. And reward center gets stimulated whenever we get all these pleasures, pleasurable news or pleasurable events. So a social media will cause a dopamine strike. And this dopamine strike will increase our pleasure, especially in this reward center, which is mainly in the nucleus accumbens and the ventral tegmental area. So when these spikes are not there, then you have the fear of missing out, lose your sleep and lack of physical activity. And they say that social media is more addictive than the smoking and drinking. And we parents allow social media in our children, though it is dangerous than the smoking and drinking. So what are the characteristics of adolescents who have a hyperactive reward system? There, for them, friends are more important. They are testing the boundaries and limits with their parents and authoritative figures. They like to be recognized and appreciated. And as I said the reward center is hyperactive, and judgmental self-control is not developed, and they have a heightened sexual arousal. And this is the time where they are introduced to the mobile screen. And even a small child has a reward system, and he gets rewarded by cartoons and seeing a small videos or some short videos. And we adults also are having reward system which gets rewarded by appreciation and some entertainment, some sexual content, or some songs, or some media, movies, like that. So the reward center is active in all the ages. Only thing is that it is hyperactive in the adolescent age group. And where their future is being formed, if there is too much stimulation on the adolescent brain, it can affect their future. So there are lot of mass media types like print media, broadcast media, outdoor and transmit media, and digital media. It is the broadcast media and the digital media, which is the interactive media, which is shown through the screen, and it affects our brains, and especially the adolescent brains. So let us go to this case 2. What are the pros and cons of this media? Mahadev is a 10th standard student. His academic and sports performance were good still recently. He uses a mobile app to study along with his mother. So he is being monitored by his mother. He also uses mobile for chatting, listening to music and see movies. But nowadays, from the last 2 months, he is sleeping late in the night, and his academic performance is beginning to come down. What could be the reason? Late night movies, okay. Maybe video gaming, okay. He may be studying more also, don't know. He may be chatting with some scientist in the other part of the world. Let us not think only negative, think of the positive. And this online fascination for teenagers is because it has got good communication. He can get into a good community because of the curiosity. He can have a lot of adventure and thrills. It is cost saving. It is just free, every social media. And he can have a sense of belonging, and especially, and it can give entertainment. As you said, he can be seeing some pornographic movies, or maybe seeing some entertaining movies. He may be getting sexually abused, he may be getting cyberbullied, and he may be losing focus on his studies because of this over-involvement in the social media, or over-involvement in the screen media. So how do we manage this? So we have all adolescents between 10 to 18 years. That's what we are legally allowed to practice. All adolescents, we call adolescents between 10 to 21 years. Okay? So these people have to be assessed in our OPD by HEDES assessment. The HEDES assessment is a psychosocial assessment, and HEDES stands for, it is a short acronym for, the H stands for home environment, E stands for education environment, the school environment, E for eating habits, and A for activities offline and online, and D for drugs, whether he is in consuming some drugs to cope with the stress, and S for suicide and depression, whether he has got any depressive symptoms or suicidal ideation. S for sexuality, how is he managing his evolving sexuality in this age group, and last S for safety. So how is he taking some precautions of the in online and offline. So after psychosocial assessment, you will know what are the areas he is lagging behind, and what are the areas to be worried about, and what are the areas we have to counsel him on. So individual counseling has to be done for this child depending on whatever you identify. Suppose if you have identified pornography in this child, you have to tell him the harmful effects of that and how to control that. And for that you need motivational interviewing. Motivational interviewing is a technique where you increase his internal motivation. I think this motivational interviewing technique has to be known by all doctors. Whenever the patient is not adhering to your drugs and whenever the patient is working against his own health, we can increase their internal motivation to do best for their health. And cognitive behavioral therapy can be given by specialists, and medications for treating associated psychological conditions like depression, anxiety, sleep disorders can be given by psychiatrists or by ourselves itself. And advice on authoritative parenting style. This is the hallmark of social media addiction, where parents have to take the major role and they have to have an authoritative parenting, where authoritative parenting means they enforce rules, okay? They discipline the child, but with support and with a providing warmth, giving an unconditional love. So they give unconditional love, they enforce the discipline in the child, and they support the child in the time of need. So when these three parts are correct, the child develops good trust and the child will be able to develop in a proper way. If the parents are authoritative or authoritarian, just like a military officer, then the problem arises. And they are usually, when the parents are authoritative, the children don't develop properly, and they may be, because of the stress, they may go into screen addiction. Permissive parents, when there are permissive parents who allow the children and they don't discipline the child, then they are more prone to get into screen addiction. And uninvolved parents, then it is left to their own course, and they will also be getting into screen addiction. So there is all complicated cases which you cannot handle can be sent to SHUT clinic, which is in Nimans, Bangalore, a service for healthy use of technology. I think there are some centers in Mumbai and Pune also. I don't know, but those can be sent. Those who are having a severe problems with the media addiction can be treated in a good neurology or a good psychiatry center. Case history 3, how media is going to affect the infants and toddlers. Mary is a young mother with infant aged 10 months. She works from home. She has many errands to do, uses TV and mobile to keep her baby engaged. Hers is a nuclear family with a husband working outside for 10 to 12 hours a day. How can screen affect infants and toddlers? What anticipatory guidance can you give to Mrs. Mary? So why early experiences matter? Newborn brain is just 333 grams, and by the age of 2 or 3 years, it becomes 999 grams, almost 3 times it grows. And it is because of the neural pathways growth in this age group. Especially if the infant is in an orphanage, the too little stimulation is also bad. And the brain neural pathways don't grow. But what happens in media exposure is, there is an overstimulation of the brain. The overstimulation of the brain by the media can cause attention problems and cognitive problems and social problems. And this can be seen here. There's a lot of media exposure that causes attention problems. If there is a play games and if they are playing with the blocks, they have to interact with the social members, then they don't have attention problems. So potential effects are, the affects the cognition, verbal IQ and emotions, dulls their imagination, prevents socialization, hampers sleep by decreasing the melatonin in the brain, and may increase the obesity and cause health problems. So we all pediatricians have to become mediatricians. We have to know the media, what are the bad effects of the media, and how to use the media. We cannot just go say that don't use the media, because media is here to stay. And we only have to learn how to use this media in a proper way. So usually what you should tell a parent is put your phone away and be with the baby when they are awake. You can use the mobile and your screen when they are asleep. Preferably use a non-screen media with the children like books and blogs. And 3 to 5 minutes of video chats with family members can be used if they know them only. Interact with respect and empathy when you are on the screen. They'll be seeing your tone of voice, your facial expressions, even though they are babies. So they will pick up something is wrong with a person when you are talking on the media. So you should be very, with empathy and respect you have to talk when you are with your children. And make memories, you play with the child, you sing with the child, you dance with the child, and make memories with your baby, so that is more important for its brain development than your screens and tablets. Interacting with humans and physical world is much more richer than any screen or any virtual world. Case 4, how can media screens affect preschool children? Arun and Dipti are young parents. They live in a flat with their 4-year-old cute daughter, Kavya. Unfortunately, there are no children of her age in the building. A servant looks after her when both the parents go to work between 9 a.m. to 5 p.m. They have given her a tablet to be busy when they go away. She also watches TV along with the servant whenever it is interesting. Play school teachers have noticed that she is aloof and does not mingle well with the playmates. What could be wrong with Kavya? No friends. Yeah, there's no social interaction with her. And she's almost with a tablet or the TV. Okay? Maybe the servant is not interacting with her in a proper way. She's not giving time for a physical. Only social, human contact is the servant. How to set it right? We'll just see. Effects of the screen time on children, it affects on the brain. The cognitive development becomes less. There is a social impairment, and there is a delay in the language development, and the sleep challenges are also there because of the exposure to the blue screen. The physical stresses can cause headaches, eye strain, poor sleep quality, and blurry vision. Mental struggles can cause poor academic performance in the older children, behavior and social issues with the older children, and increased anxiety and depression. And long-term concerns can be increased risk of myopia, and there may be increased risk of childhood obesity. So how to manage this screen-addicted child of a 4-year child? According to our DSM criteria and our ICD criteria, they don't classify mobile screen addiction as an addiction proper itself. They call it as impulse control disorders. They fall under control of, still the DSM-5 doesn't classify this as a screen addiction. Request a balanced approach for this 4-year-old child. Set clear limits. Structured screen-free times has to be given. Avoid screens during meals, morning and bedtime. Creating stopping cues. Use timers to signal the end of the screen time. Encourage alternatives like in-person social interaction with family activities, play dates, and playing with other similar age group children. Engage in age-appropriate activities beyond the screens. Use parental controls. Parental controls are available in Microsoft. They are available in Google. And you have got some apps also like Net Nanny, McCafe, where they have got some parental controls so that you can limit the timings where these children can use the screen. Behavior modification has to be done for severely affected children. And remember, gradual changes and consistent boundaries can help address screen addiction in the young children. So what would be the pediatrician's guiding points to prevent this from occurring? The parents have to develop social, emotional, and cognitive skills off the screen. And main thing is, parents have to be the good role models. They have to limit their screen time. Screen should not replace child's play time, story time, interaction with friends, and sleep. Avoid using screens as a babysitter to regulate child's emotions. Most of the homes, this screen is used as a babysitter. Can use interactive media to learn by asking questions. You can ask questions whenever there is a story, whenever there is a movie, whenever there is an advertisement going on in the screen, when you're watching with a child, you can always ask questions so that the critical thinking capacity of the child increases. How much time do I have? 6 minutes. So this will be my last slide, last case. So Karan and Poonam are siblings studying in 7th and 5th standard. Father works outside home and mother is a homemaker. They have given tablets to them with good Wi-Fi and their education and entertainment. Mother after work is usually busy on TV shows and social media. She is more of a permissive parent who wants to see her children happy. Karan and Poonam like to listen to the YouTube songs, watch cartoons, watch TikTok videos, and play games on their tablet. They are falling behind in studies since last 6 months. They don't like to go outside and play. This is what is happening to the present day children. They don't want to go outside and play. They want to play inside the house with a screen. So what can be done to this family to prevent media and internet related health issues? So there are some scales for measuring the smartphone addiction in children. They are called as smartphone addictive scale version, shorter version, smartphone addiction proneness scale, mobile phone use scale, problematic mobile phone use scale, nomophobia questionnaire. These are available on the internet and you can use them whenever you feel the media addiction is problematic in the child. So management of screen addiction in school children is cognitive behavioral therapy by a good psychologist or a mental health professional, mindfulness, where the overstimulation of the brain by the screen is prevented, so they are focusing on only one object. Can also help. Journaling of smartphone use, writing in a book or a diary how much time he has been using the screen can help them to become self-aware, and they can use that information to self-control themselves. And authoritative parenting. In this case, the mother was permissive. If authoritative parenting where good discipline, good support, and good unconditional love is given, they can guide the child to use the screen in a proper way. And school policy, family therapy can be given where sometimes the grandparents are more permissive than the parents. And whole family, when it is advised together, they'll be able to guide the child properly. School policy of not using the mobile for entertainment or school policy of not bringing the mobile to the school is very important, and sometimes you need exercise rehabilitation for the bad effects of screen, overuse of the screen. Intervention apps like App Detox app and Nugu app, no use, good use. This is an app which can control the amount of interventional apps. They can tell you are using the screen for too much time and you can control it. And psychopharmacological drugs can be used for depression, they can be used for anxiety, they can be used for substance use, they can be used for sleep disorders, and this will help to control the severe effects of screen on the children. What should a pediatrician do to prevent this? How does he guide the parents? You have to tell the parents to develop schedules with good parenting skills. Create family expectations. Avoid screen limits, but sit down with the child. At least one family meal together without the screens. Model healthy media and behavior. Develop media literacy together. Establish effective study habits early and manage access to device and contents. Balance digital and physical worlds. Balancing, we cannot survive without this media, without this internet. We have to balance this digital and physical world so that the child grows in a healthy way and it does not affect his social and mental health. So last case, this is in brief. 17-year-old Pranita befriended Sanjay on Instagram. This is a true story. 2 months back, they used to chat with each other and have video calls on many occasions. On one such video call, Sanjay asked Pranita to strip down. She was taken aback and refused. Sanjay took a knife in video call and threatened to cut his wrist if she did not oblige. She got afraid and did what he said. He secretly recorded the event and sent a video to her. He told her that he will make the video viral if she did not pay him money. Nervous about whom to confide, she started paying and stealing money from the house. This is a true story which has occurred in Mumbai. And she was caught stealing at the 7th time. She was paying 10,000 rupees every month. And the 7th time, the mother caught her stealing the money. So, sextortion red flags are there. What are the red flags? The person who does not have a working camera, who doesn't have a conversation, does not add up. Person turns conversation to adult right away. Profile has limited photos. Use of fear tactics and misspelled words on profile. Profile has low followers of friends. Fast-paced contact. And sextortion online or blackmailing. What we parents have to do is never post, ask the child never to post personal information online, use strict social media privacy settings, be cautious on dating apps, and never accept friends' requests from unknown people, never click on unverified links, and do not accept video calls requests from the unknown members. And even virtual rape can occur in the virtual world. So this case has happened in England where the child was using an avatar for himself in a metaverse, that is in virtual reality, and she was raped by the other avatars in this thing. This was the first case which has happened. So many things can happen. And I hope that there was a short video about robots previously, I think in the second lecture or the third lecture. I hope these robots will not be replacing the parents after some time, because most of the parents are busy and they want some parent-like figures. Usually parents who come to my practice, I tell them that if you both are parents are busy working, you create parent-like figures in the house who will provide good discipline, who is going to give good unconditional love, and who can give good support to the child. They may be grandparents, they may be aunt, auntie, or you can even train your servant if she is intelligent enough, or your maushi who is working in the house. You can train her to be a replacement for you, not to take all the parts of your parenting, to some parts of parenting till you come back and stay. So summary, 5 M's have to be followed in this digital world, screen world. You have to be a good role model. You have to be a good mentor. You have to monitor your child from birth to they become independent or till they are 25 years. And make memories with your children off the screen. And you also learn about the screens along with the children. And master the screen media. Most of the time the children are ahead of us. And the screen is dynamic. The media, internet is dynamic and it changes day by day. You keep ahead, keep abreast with your child, and be with the infants and toddlers. Prioritize books, music, and non-screen play. Interact with humans and physical world is much richer than the screen. Model and teach critical viewing of the media. Coach about how to avoid dangers in the digital media. Meal time, sleep time should be free from the mobile. Develop schedules and make media use agreements with your child. Develop media literacy together. Be aware of red flag signs and technology addiction. Seek help and refer early to mental health specialists. This is very important of referring to the mental health specialists early. If you refer them late, then it will be a problematic again. It is going to take a lot of time for recovery. These are 2 books which are very useful for guiding pediatricians and parents equally. This is the Pediatrician's Guide is written by Dr. Michael Rich. He is from Boston Children's Hospital. He is a pediatrician who has written this book. And Behavioral Disorders is from India. It is edited by Dr. Piyush Gupta sir. And this is also an excellent book which can help us to guide our patients, our children, to be safe from the media and screens. Thank you so much.
Sir, we have discussed one case, 10 months old child. So what are the criteria to introduce this screen to the children? Is there any criteria, like at what age you should introduce or how much time you should?
Actually, any child below 3 years, they say you should not use the screen at all. Only you can use the screen for 3 to 5 minutes, where you are talking with a grandfather or an uncle whom they know.
So FaceTime?
Yeah. Otherwise, they are not supposed to use any media because the brain is growing very fast. They need the physical world for that.
There was one more question that in one of the case we have discussed that the parents are not in, they are busy in working. So in that case, is there particular apps you can suggest where we can control the child's mobile and child's internet use?
Yeah, there are some apps like Net Nanny. Okay, so Net Nanny app is there. There are so many apps actually. I know I'm telling you only one name. You can search out. So this Net Nanny is a one. These apps, what do they is, they know how much time your child is spending time on these screens. And sometimes if the child is younger, they tell you in what apps they are going forward and what they are doing. But if the child is adolescent, they want to keep their privacy and they don't tell what he is doing on the screen, but you will know how much time he is spending on the screen.
Sir, there is one more question that regarding the scenario which you have given, but many a times we come across that children are watching mobile while eating food and all, and even in-house, the parents are watching the TV serials and the news and everything. But they tell us that, no, he just watch for 15 minutes and he doesn't pay attention for TV and all. So how do you grade that? I mean, what you will suggest to the parents?
Any media which is used along with the food, it is not a healthy sign because he doesn't know what he is eating. The texture, the taste of it is always, the brain is preoccupied with whatever he is seeing on the screen. A better combination would be a parent offing the screen, TV screen, better option, the best option, okay? And baby offing the mobile screen, sitting together, enjoying the meal together. That is the ideal situation. That is the ideal situation. And that's what is advised.
Okay. And there are few terminologies like background screen. What you want to say about that?
Background screen?
Background screen, because something is going on behind, and does it affect on the child's development?
I don't know about that. I don't know.
Thank you, sir.
Thank you, sir. Thank you, chairpersons. I request that dignitaries to proceed to the felicitation area. Moving on to the last session for the day. Childhood hypertension and hypertensive emergencies. This talk will be delivered by Dr. Venkatesh Tarkasband sir, and the chairpersons for this session are Dr. Ravi Pawar sir and Dr. Hemant Bharti sir. Dr. Ravi Pawar sir is a pediatric cardiologist practicing in Kolhapur, and Dr. Hemant Bharti sir is HOD and professor in Department of Pediatrics, Prakash Institute of Medical Sciences in Islampur.
Good afternoon, everyone. Dr. Venkatesh Tarkasband, he's a pediatric intensivist and doesn't require much introduction in this part of the world. And sir has many national and international presentations and publications under his belt. Today he is going to tell us about hypertension in children and hypertensive emergencies. So over to you, sir.
Yeah. Good afternoon, all. First of all, I am very much thankful to the organizing team, Kapcon 2024, for giving me the opportunity to share my experience in this field. So without wasting much time, I will be starting with my lecture. To judge the volume of this problem, I will start with the case. So this is a 10-year-old girl who was we had a road traffic accident. She was going from the two-wheeler, she was sitting on the backside, and she fell down from 2 to 3 feet and was thrown on a stone, and she had a blunt trauma to the abdomen, chest and head. So she was brought to the casualty. She was deadly pale, she was hypotensive on admission, and marked tachycardia. And on the echo screening, ultrasound screening, she had a hemoperitoneum and massive hemoperitoneum pneumothorax. So immediately she was resuscitated by fluids, and then she received 4 blood transfusion next 12 hours. And that she got stabilized. So after stabilization, we investigated her. The CT scan of abdomen, chest, and brain was done. The CT abdomen show grade 4 kidney injury with a massive hemoperitoneum. The CT chest showed hemothorax with a fractured rib, and the CT brain was normal. So you can see, this is the CT abdomen. You can see there is a frank hematoma inside the kidney. Kidney is totally fractured, and the upper pole and the lower pole of the kidney were just connected by a small segment. So it was a grade 4 renal injury. Surgeon advised conservative management because after giving blood transfusion, she became hemodynamically stable. She was shifted from the PIS to the ward. Otherwise, she was stable. So for just continuation of the antibiotics and all, she was shifted. She was kept in the hospital. But unfortunately, one day after shifting to the ward, she had a generalized tonic-clonic convulsion. We were wondering why she had a seizure. So again, she was taken to the PICU. Then we thought she had a head injury on admission, so could be some CNS problem might be there, which is not picked up by initial CT, like diffuse axonal injury. So we got an MRI done. MRI was normal, and once she came from MRI, just as a routine, we checked the blood pressure, and the blood pressure was 200 by 140 millimeter of mercury. And so she was disoriented, drowsy. So she was in encephalopathy. So she was started on labetalol drip, and slowly the blood pressure reduced in next 4 days, and she was discharged after 4 or 5 days on oral antihypertensive drugs. She was neurologically normal. So this is a case of hypertensive encephalopathy, which we encounter, presented as a simple case and then diagnosed to have a hypertension in the hospital. So the prevalence of hypertension. So what the data says that it's around 1 to 2%. So out of the 100 OPD patients that we see, around 1 to 2 patients may be having hypertension on some other day. And in last few years, after COVID-19, there is a surge in the prevalence of hypertension to around 4 to 5%. So there is 3 times increase in the number of hypertension. Obesity is a predisposing factor, and severely obese children, the prevalence is as high as 10%. Primary hypertension is on the rise, predominantly in the adolescent age group because of the academic stress and lot of competitive environment in the schools these days. And as the adolescent age group is included in the pediatricians area, so we'll see a lot of patients, our patients finding hypertensive. So hypertension may be primary hypertension when there is no underlying causes found, or it could be secondary hypertension. Primarily in children, till now we were seeing predominantly secondary hypertension, but now the trend is little changing. So we see a lot of primary hypertension as well. The lowest age we see as low as 6 years also, primary hypertension. A lot of pediatric nephrologists I have discussed before preparing this presentation in Mumbai and different places. So they also have a similar experience that a lot of primary hypertension they are seeing at little low ages. So what is the definition of hypertension? So there are blood pressure normograms are available for different ages and heights for boys and girls. So initially the terminology for a mild hypertension was a pre-hypertension, but now that terminology has changed to elevated blood pressure. So whenever the blood pressure lies between 90 to 95th percentile for that age, sex and height, it is known as a elevated blood pressure. So a single reading of high blood pressure should not be labeled as a elevated blood pressure, but you have to follow this child. So at 3 different visits, if you get a persistently high blood pressure in that range between 90 to 95th percentile, then you label that particular child as a elevated blood pressure. These definitions are very important from treatment perspective, because treatment again depend on which category of hypertension the child lies in. Whereas in hypertension is labeled when the blood pressure is above 95th percentile. So stage 1 hypertension means when blood pressure is above 95th percentile, but not more than 12 millimeter of mercury. Whereas stage 2 hypertension is a little more severe when the blood pressure is above 95th percentile by more than 12 millimeter of mercury. To simplify that, I will just give an example. If for the particular age, sex of the child, the blood pressure 95th percentile is suppose 100 millimeter of mercury. So if the blood pressure lies between 100 to 112, it is labeled as a stage 1 hypertension. Whereas if the blood pressure is going beyond 112, then it is a stage 2 hypertension. So when you detect a stage 1 hypertension, you have to call the patient after 1 week to check the blood pressure. Whereas stage 2 hypertension, you ask the patient to wait in your OPD. Again, after 1 or 2 hours in a quiet room, when the child is quite comfortable, you recheck the blood pressure. So I'll just discuss about a few practical points in hypertension. So as you all know, there is a systolic and diastolic blood pressures. So in children, isolated diastolic hypertension is very unusual because of the atherosclerosis and vascular elasticity is well maintained in children as contrast to the adults. So for all practical purposes, give more focus on a systolic blood pressure. Whenever you are taking a blood pressure and you are struggling checking the diastolic, just forget it. Check only systolic blood pressure. That is more than sufficient. So if these nomograms are not available when you are going out or something, so you can use this formula that 95th percentile for that particular age is equal to 100 plus age into 2. For example, for a 5-year-old child, you can see the 95th percentile will be 110, sorry. So this is a rough formula for the diagnosis of hypertension. And then depending on that, you can grade it, either it's a stage 1 hypertension or stage 2 hypertension. Screening for blood pressure is very, very important because hypertension is a silent killer. Unless we measure the blood pressure, we will not come to know that whether this child is hypertensive or not. And hypertension has a very adverse effect on the body. So what are the silent effects of hypertension? So asymptomatic hypertension, almost 40% of the children will have a left ventricular hypertrophy. Retinal changes will be present in around 10 to 15% of the children. Increase intima to media thickness in the carotid artery, very important. So this predisposes the child for the development of strokes. So, and again, microalbuminuria in the urine. So these are the silent damages the hypertension is causing in the body. That's why screening is essential. Again, primary hypertension in children, if we don't control at right time, there is a 3 to 4 times more risk of developing adulthood hypertension. And 50% of the adults who are hypertensive, their hypertension starts in childhood. So we know that there is a tremendous volume of hypertension in adults. So almost 50% of these adults, the hypertension has started in the childhood. So definitely there is a high volume of hypertension in pediatric population these days. How to screen the hypertension? So all children above 3 years of age, we should have an annual check of blood pressure. And even if the child is less than 3 years of age, with high risk factors, we should check the blood pressure at least once in a year. So what are the risk factors? So these are list of risk factors. So common is a prematurity and very low birth weight baby. So all we are managing lot of neonates these days, and babies less than 1 kg are surviving with good neurological outcome. So in these babies, the risk of hypertension is as high as 7.2%. So it's quite high risk of hypertension. And we don't monitor these babies for blood pressure in the further life. So we should start doing that. And there are so many other risk factors. In these cases, we have to monitor the blood pressure even if the child is less than 3 years. So how to measure the blood pressure? It's a like a routine MBBS time we are checking the blood pressure, so nothing change in that. But in children specifically, we should be checking the blood pressure once the patient is in a comfortable position, should not immediately rush, but we should give some 5 to 10 minutes for the child to settle in a quiet room. And while checking the blood pressure by applying a sphygmomanometer on the arm should be at the level of the heart. This precaution is to be taken when we are checking the blood pressure in a sitting position. Sphygmomanometer measurement is the gold standard measurement. You should not rely on NIBP or electronic blood pressure devices because they check the mean arterial pressure, and indirectly from the mean arterial pressure, they derive systolic and diastolic blood pressure. So for accurate measurement of the systolic blood pressure, sphygmomanometer is the gold standard. NIBP can be used as a screening tool, and all the high readings should be confirmed by the sphygmomanometer. So how should be the cuff size? This is a common question that everyone's faces in day-to-day life. So the blood pressure cuff should cover the length should cover the whole circumference of that particular limb, or at least 80% of the circumference of that limb, and the width should be half the circumference of the limb. Right. So roughly the length should be the width should be half of that of the length. Length should cover the whole circumference, and width should cover the half circumference. So these are the guidelines given by the American Academy of Pediatrics. So there are different size BP cups are available, so you can use that. But whenever the right size BP cup is not available, it should not be an excuse not to measure the blood pressure. For example, if you don't get a right side, use a little larger size BP cup, but don't use smaller size BP cup, because smaller size BP cup will erratically give the high reading. So this is the child who is 2 years old. When the pediatric size BP cup is not available, you can tie the sphygmomanometer cuff to the leg and auscultate on the dorsalis pedis artery. What are the symptoms? Most common symptoms is a no symptom, because it is unless it's a very late stage or very high blood pressure, it doesn't cause symptoms. So in elder child, you can get a headache, vomiting, dizziness, excessive sweating, and whenever there is a very severe hypertension, it can cause encephalopathy and respiratory distress. So whenever you detect a hypertension, you should give more importance to this history, that is perinatal history, diet history, how much is the dietary intake of sodium and salt, physical activity, how is the physical activity, and how is the psychosocial history. Recently, sir has finished the talk on the screen time. So a lot of children, they are like this young generation, adolescent, they are under a lot of stress, or they have a lot of psychological disturbances. So that again increases the risk of hypertension. Then family history of hypertension. So coming to the causes. So neonatal hypertension. So very low birth weight babies, umbilical artery catheterization with a secondary renal artery thrombosis, bronchopulmonary dysplasia, and recently we see a lot of patients with MISN, multisystem inflammatory syndrome in neonates, and so many of them we've detected to have a hypertension requiring antihypertensive therapy. Then hypertension may be acute or transient hypertension, or sustained or chronic hypertension. So what are the causes of acute hypertension? As everyone is aware, it's a post-infectious glomerulonephritis. Around 20 to 30% of the patients with nephrotic syndrome can have a hypertension, Henoch-Schönlein purpura, HUS, trauma, and acute renal failure, infections like pyelonephritis. and of course the tumor, renal tumors. As far as the CNS is concerned, any CNS insult, either it may be trauma, it may be SOL, it may be some infections, meningoencephalitis, hemorrhage, status epilepticus, all these things can cause hypertension. And of course the Guillain-Barré syndrome. So in Guillain-Barré syndrome, the hypertension is a part of autonomical disturbances. They can have a hypertension, they can have a hypotension, they can have brady, tachycardia. So it's a part of autonomic disturbances. So in Guillain-Barré syndrome, the hypertension should be treated, but not in central nervous system problems. So why we should not treat this hypertension? Because you just see this formula, that is cerebral perfusion pressure. Cerebral perfusion pressure is the pressure at which the brain cells receive the blood supply. So the cerebral perfusion pressure depends on the mean arterial pressure and intracranial pressure. So whenever there is any CNS injury, the ICP goes high. And it's a body's compensatory mechanism that increases the mean arterial pressure to maintain the cerebral perfusion. So if we treat this patient by reducing the main airway pressure, your cerebral perfusion, because the ICP has increased and MAP has not increased, so CPP will come down and there will be permanent neurological damage. So we should never treat the hypertension in the case of raised ICP. Various drugs can cause hypertension, commonest is steroids. Then a lot of cough syrup, cold preparations are having that phenylephrine, decongestant. That again can cause transient hypertension. In PICU setting, fluid overload, pain, anxiety, a lot of connective tissue disorders with vasculitis can cause hypertension. In chronic hypertension, most commonly it is a renal, CRF, nephropathies, renovascular, then renal artery stenosis, dysplasia, fibromuscular dysplasia, cardiac could be because of coarctation, aortoarthritis. Many of the times the blood pressure is high. In echo may or may not pick up this aortoarthritis. It could be because of tuberculous aortoarthritis or syphilitic aortoarthritis. Endocrinal causes, hyperthyroidism, diabetes, type 2 diabetes. Lot of patients of type 2 diabetes we are seeing these days. So around 10 to 15% of these patients can have associated hypertension. Then Cushing's disease because of glucocorticoid excess, hyperaldosteronism because of excessive fluids, and of course pheochromocytoma, catecholamine secreting tumor can have a hypertension. So what should be the diagnostic approach? Whenever there is documented hypertension, check the gradient. If there is an upper lower limb blood pressure difference, then straight away diagnosis is coarctation. If there is no gradient, check the urine. The urine is showing predominantly WBCs, then it probably reflux uropathy. If these are predominantly RBCs, then could be nephritis, post-streptococcal nephritis and all that thing. And if the urine is bang normal, it could be essential hypertension, it could be hormonal, or it could be renovascular. So what investigation? So investigation for the etiology and ultrasound. So ultrasound with a renal Doppler. So Doppler has only sensitivity of only 50% for diagnosing of renal artery stenosis. So we should go ahead with either CT or MRI. So both have a specific sensitivity of around 85 to 90%. Echocardiography should be done at least once in a year for documented stage 2 hypertension to check for the left ventricular hypertrophy. Carotid Doppler and retinal examination should be done yearly. Then ambulatory blood pressure monitoring. Why it is important? Because many of the times just single reading in your clinic may not suffice to confirm the diagnosis of hypertension. So it's a continuous blood pressure trend we need to see. And 2017 American Academy of Pediatric Guidelines recommend that routine use of that ABPM is essential. Because white coat hypertension and mask hypertension. So what is white coat hypertension? Whenever the child comes to your OPD and the blood pressure in the OPD is high, but at home the blood pressure is normal, he is known as a white coat hypertension. So this cannot, and it's a mask hypertension is on opposite. Whenever the patient comes to the clinic, the blood pressure is normal, and it is high at home. So both these things, for confirmation, we need to have this 24-hour blood pressure monitoring. So as far as the treatment of hypertension, elevated blood pressure or uncomplicated stage 1 hypertension, you should wait on lifestyle modification for at least 6 months. So what comes in lifestyle modification is, of course, weight reduction. Lot of children with obesity we see these days. Increased physical activity, meditation. Just single meditation for 15 minutes is proved to reduce the blood pressure by 4 millimeter of mercury. Then DASH regime, that is dietary approach to stop hypertension. So salt restriction to less than 1.5 gram per day, no added salt, no fast food, and increase the potassium and calcium, magnesium, folic acid in the diet has drastically proved to reduce the chances of hypertension. Indication of starting treatment, stage 2 hypertension and stage 1 hypertension with comorbid conditions, and stage 1 hypertension which persists in spite 6 months of lifestyle modification. Principle of the treatment, target should be to reduce the blood pressure less than 90th percentile. Always use a single drug with a low doses to start with, and then increase the dose to the maximum level before adding a second drug. Always prefer long-acting drugs because of better compliance, and once a day schedule is always better, and that dose has to be given at the night time and not in a daytime, because initially there is a physiological response is like in the night time, during sleep normally blood pressure drops, but in hypertension that drop is not there, so HS dosage has to be preferred. So various drugs, I will not go into details of that. So commonly used is most commonly nifedipine, amlodipine. So amlodipine is better because it was available in the once a day schedule, but nowadays extended release nifedipine tablets are also available. So nifedipine can be used. ACE inhibitors, again enalapril is better than captopril because of the once a day schedule. Then angiotensin receptor blocker, losartan, it's very commonly used these days to manage the hypertension. It's a long-acting drug and has an excellent results. Beta blockers can be used, propranolol, atenolol, or metoprolol. Labetalol, so more focus is using this labetalol because it has alpha and beta both action, and beta action is a more prominent than the alpha action. So it's a wonderful and very safe drug in children. Diuretics, of course, when in volume overloaded situation in hypertension, particularly we use diuretics. Alpha blockers, prazosin. It has a very fast effect and had a reduces the blood pressure drastically. Central alpha-2 agonist clonidine, then vasodilator like hydralazine and minoxidil. They are very potent drugs, so should not be used initially. So later on, the blood pressure if it's not getting controlled, these drugs are required. So this is a hypertension algorithm. So whenever there is a documented hypertension above 95th percentile, start either with calcium channel blocker or ACE inhibitors, and give a time for 3 days. If still blood pressure is remaining above 95th percentile, then do a combination. If you are reaching the maximum dose, then combination, either calcium channel blocker or plus ACE inhibitor, calcium channel blocker or beta blocker, or you can add a ACE inhibitor with diuretics. Still BP is high, then add a prazosin. So prazosin is a better tolerated drug in children. So it adds as a third line of drug, and if still BP is high, clonidine, hydralazine or minoxidil. So this should be the protocol. Then choice of antihypertensive as per the etiology. So whenever you get an acute glomerulonephritis with hypertension, prefer calcium channel blockers and diuretics because it's a volume overloaded situation. Whenever there is a CKD, lot of patients with chronic renal failure, they have a microalbuminuria, and enalapril or ACE inhibitors or angiotensin receptor blockers, they reduce this albumin loss from the urine, so they are preferred drugs. Then CKD with poor renal function, beta blockers and calcium channel blockers. Renovascular hypertension, beta blockers can be used, but if it is, or ACE inhibitors can be used if it is a unilateral renal artery stenosis. In bilateral renal artery stenosis, ACE inhibitors are contraindicated. And the phenoxybenzamine is a drug of choice for pheochromocytoma because it is a alpha blocker. These hypertensive children should be followed every 3 monthly when they are on lifestyle modification and monthly when they are on a pharmacotherapy, and they should be normotensive for at least a year before tapering the drug doses. So I'll be coming to the hypertensive emergencies. So many of the times we get severe hypertension with a significant symptom. So hypertensive urgency and hypertensive emergency, we need to understand what it is. So whenever there is a very high blood pressure without end organ damage, it is known as a hypertensive urgency. Child can have a severe headache, vomiting, dizziness. Whereas in hypertensive emergency, there is an end organ damage is already present. Maybe convulsion, encephalopathy. In ocular, you can have blindness, hematuria, renal failure, and CCF. So what are the principles of hypertensive crisis is? It's a medical emergency and has to be addressed immediately. So absolute value of blood pressure is not important, but the rate of rise of blood pressure is more important. For example, if yesterday the blood pressure was 170 and today it's around 220, 140, so it is very important. So that's why you should be more aggressive if it is rapid rise in blood pressure. So intra-arterial line is very important. We have to continuously monitor the intra-arterial blood pressure, and NIBP is of not use or not reliable in such an emergency situation, and slow reduction of blood pressure is very important. Whenever there is very severe hypertension or hypertensive emergencies, body has adapted for that high blood pressure. So sudden reduction in blood pressure will cause organ hypoperfusion, and commonest problem which we face is blindness because of rapid reduction of blood pressure. So 1/3 of the hypertension should be corrected within the first 4 to 8 hours, 1/3 should be corrected in the next 12 to 24, and 1/3 should be slowly over 2 to 3 days. So in hypertensive urgency, which drug you should use? It's not that severe condition, so you can use sublingual nifedipine. You can repeat after 30 minutes. If still the blood pressure is not coming under control, then hydralazine, clonidine, or minoxidil. These are the oral drugs that you can use. Whereas in hypertensive emergency, it is a very life-threatening situation. You have to use a potent antihypertensives like sodium nitroprusside or NTG. So sodium nitroprusside dilates both arteries and veins. Action starts within 30 seconds. And only thing is it's photosensitive, so we have to use the aluminum foil while giving the infusion of sodium nitroprusside. So nitroglycerin is a safer because it's a predominantly venodilator, doesn't causes blood pressure, reduces that rapidly. So my personal experience is nitroglycerin is better tolerated than sodium nitroprusside without much adverse effect. Labetalol, in last few years, labetalol is extensively used in children for these hypertensive emergencies, and it has a very very great safety margin. So it's a predominant beta blocker. Alpha action is there, but beta action is predominant. So it can be used, but only thing is being a beta blocker, you can't use it in a CCF and asthma. Then these are nicardipine, hydralazine also available, but very rarely we require it. So I'll come with one case. See, this is a 2-year-old child. He is the second product of consanguineous marriage. He was diagnosed to have a congenital nephrotic syndrome at the age of 6 months. So initially started on steroids, but no response to steroid as expected, and he developed chronic renal failure with creatinine of 8 at the age of 9 months, and he was started on CAPD. Couple of minutes. Then he was started on 3 antihypertensives, and he is due for renal transplant. So last 15 months, the child is on CAPD and following with us, and we are arranging the donor for the renal transplant. Surprising positive history, the elder sibling also has a congenital nephrotic syndrome, and he died at the age of 1 year. And whole exome sequencing was positive for congenital nephrotic syndrome, and consanguinity is also there. So this child has presented with acute severe respiratory distress, brought in a very hypoxic condition. Tachycardia, tachypnea was there, and blood pressure was 86/70 millimeter of mercury. So it was reasonably normal. This is the X-ray chest. So we thought he's an immunocompromised child, so could be some infection like viral pneumonia. bilateral haziness is there. So we got investigated, the COVID H1N1 is negative. We intubated, the child required very high ventilator setting, the PWP of 14 to maintain the saturation. So as the echo screening was done, that was showing bilateral dysfunction, ventricular dysfunction, the dobutamine was added. And after dobutamine addition, within 1 hour, the BP jumped up to 180, 120. So basically the child, this is a hypertensive cardiac failure. And because of cardiac failure, wrongly the blood pressure and admission was detected low. Once we correct that cardiac failure, the blood pressure jumped up. So this patient required nitroglycerin infusion. So we reduced the blood pressure from 180 to 150 in 8 hours, from 150 to 120 in 12 hours, and 120 to 90 in next 3 days. And this child, we added two more oral antihypertensives and discharged after 4 to 5 days. So this is last slide. So perioperative management of pheochromocytoma. So occasionally we see children with a pheochromocytoma, and perioperative management is very, very crucial for the best outcome. So this child has presented with us with a history of severe headache, vomiting, and diagnosed to have a severely hypertensive. Investigation revealed pheochromocytoma. So we stabilized the child with nitroprusside and then added a phenoxybenzamine. So the protocol for pheochromocytoma surgery is, before surgery, the child should receive alpha blocker for at least 1 to 2 weeks. So we continued that, and once the patient is stable, the blood pressure has normalized, the patient was planned for the surgery. So again, on admission, when we taken the patient in the operation theater, the child's blood pressure was 110 by 17. We started sodium nitroprusside drip, and we kept noradrenaline drip ready, because during this intraoperative period, the blood pressure fluctuations are very much expected. So everything was kept ready. While the surgeon has taken the incision, the blood pressure was 110 by 70. While the tumor was handled at the time of surgery, blood pressure, in spite of sodium nitroprusside drip, rise from 110 up to 240 within a minutes. And then that is managed by increasing the dose of sodium nitroprusside to the maximum dose, 5 microgram per kg per minute. And then once that tumor was separated, and then before tumor was cut, they tied the vascular pedicle. So once they take a ligature over the vascular pedicle, the entry of catecholamines into the systemic circulation has stopped, and within a minute the blood pressure dropped to 70 by 30. So child became again hypotensive. So this is managed by giving a noradrenaline infusion. So the child was receiving both noradrenaline on one side and sodium nitroprusside on the opposite side. And somehow this patient, in next few days, we titrated and stopped both the medicines. And this child was discharged without any antihypertensives. Surprisingly, again after 2 years, this child had a pheochromocytoma on the opposite side. It was very unusual, and this time it was non-secretory, because blood pressure at this time was normal. But because of two pheochromocytoma on both the sides, we got a whole exome sequencing done, and that came positive for multiple endocrinal neoplasia. So my take-home message is hypertension is much more common than we expect. Early diagnosis and treatment prevent the permanent damage. Systolic blood pressure is more important in children. Never treat hypertension in the raised ICP, it's detrimental. And in hypertensive emergency, gradual blood pressure reduction is most essential. Thank you.
Thank you, Dr. Taraksban. My question is that you talk about the essential hypertension that is upcoming in the adolescent period. So how will follow these children? Because in adults, routinely they are doing the lipid profiles and other tests routinely every 3 months, 4 months, 6 months. So here you are advising for the LDH and all the things?
Yes, sir. At least once we confirm that it is a essential hypertension, we get a comorbid screening done in the form of lipid profile and blood sugar. If that is abnormal, we simultaneously treat that also. And of course, the first therapy, even in essential hypertension, will be the lifestyle modification. And then basically the chances of left ventricular hypertrophy are more in children as compared to the adults. So echo once in a year is essential. And of course ophthalmic and carotid artery Doppler, maybe at 1 or 2 years interval to prevent the complication. Many of the times, recently we had unexplained stroke. All coagulation profile is normal. And if we check the blood pressure, the child was found to have a hypertensive with a echo, which is suggestive of severe LVH, so long-standing hypertension.
That is necessary. So this take-home message is that you have to take blood pressure of every child, those who are coming.
Yes, sir. That is in screening. We have to take at least once in a year.
Then routine OPD, we have to check the blood pressure if the child is having obesity. So.
Yes, sir. Yes, sir.
Thank you. Thank you for your kind presentation. Thank you.
Yes, sir. Yes, sir.
IAP is not officially recommending, but at 5 years of age, we should. MMR vaccination is a good opportunity to.
Previously, what we are thinking that hypertension in children is mostly because of the renal cause. But nowadays, it is essential hypertension is upcoming these things. Right.
Yes, sir.
Okay, thank you.
Thank you. Thank you all.
Thank you, Venkatesh sir. Thank you, chairpersons. I request all the dignitaries to proceed to the felicitation area. I request Dr. Shraddha ma'am to proceed with the next.
Goes to Dr. Forum Koradia from GMC Mirrors. Topic was case series of neonatal IEM. To give away the poster competition prizes, may I call upon Dr. Nivedita Patil ma'am, Professor and Head of Department, D.Y. Patil Medical College, Kolhapur. Anuradha Gupta from RCSM GMC Kolhapur. Her topic was rare case of Rennie syndrome. Second prize goes to Dr. Arvindam from D.Y. Patil Medical College, Kolhapur. His topic was multidisciplinary approach in a case of Evans syndrome. I invite Dr. Rahul Patil sir for the valedictory function. May I call upon all the executive body members to the dais?
Yes. Good afternoon, everyone. So, after this successful event, I would like to thank first all the faculty members and chairpersons of Kapcon and workshop, IYCF workshop, for sparing their valuable time. I would like to thank all the office bearers, President Dr. Sainath sir, Treasurer Dr. Prama Bhapna, and EB members, Dr. Shraddha Kulkarni, Dr. Ruchika Yadav, Dr. Milind Sadavarte, Dr. Rupali Patil, Dr. Maheshwari Jadhav, Dr. Kashmiri Badbade, who worked tirelessly for last 3 months to make this event successful. I would like to thank scientific committee, Dr. Mahesh Kore sir, Nanivdekar sir, and Nivedita madam for their valuable inputs. I would like to thank specifically all the residents without whom this event will not be successful. So all the residents of D.Y. Patil Medical College and RCSM GMC who have volunteered in this event. I also thank Master of Ceremony, MOC, Dr. Shraddha Kulkarni, Dr. Sancheti Patil, and Dr. Pratima Patil, who has done excellent work. I also thank management of Sayaji for providing excellent ambience and food. I also thank all the pharma companies and their representatives for their support. And thank Mr. Swarup Lohar for excellent audiovisuals. And also thank Mr. Ashraf for making stall and stage arrangements. And also important person, Mr. Ved Patak, who has done digital media preparations. Last but not least, I would like to thank all of you delegates, without whom this event would not be successful. Thank you once again.